proposed because of something which I'll come back to in a few slides. So this is the MSK A to Z, and just a quick recap because some of you have not attended the previous sessions. Just to give you the context of this A to Z course. This is a course which we devised years ago, I think 2007, 2008, in which we cover whole of radiology from the perspective of the FRCR 2B exam. And we used to cover actually one system per day. So it was a super saturated course done on 8 weekend days. And the idea was to cover whole of radiology from the perspective of the exam. Now, because of Zoom, or because of COVID, should I say, we got this idea to start this course online. And we developed this web portal, and now you can register and you can go through it. The concept of this course is that I show you cases in a textbook manner with sort of 2B format. So all cases which have come in the exam or which can come in the exam, those cases is my mandate to show you. This is what I call a foundation big course. It is not a mock exam course. It is not a mock exam course, and I always tell my students that this type of a course should finish maybe about 1 month before the exam, and in the last month candidates must book mock exam courses. My formula is at least 3 mock exam courses, and also rapid reporting course. The Northwick Pass course, of course, is well renowned for that, quality wise. So with that background, regarding COVID, initially the idea was to teach the ST1s, and I do teaching on Thursdays. This is a every Thursday I've got a 3-hour session. So the idea was to teach the ST1s, and in 2 years' time to take them to the level of FRCR 2B. But because the exam was announced by the RCR 2 weeks ago, so we thought that we will slightly revamp the program, and in about 12 to 14 weeks finish whole of the curriculum, of course targeting the ST4s, particularly the people who are sitting the exam. Please remember that this time the exam is only for UK candidates. Now, that makes it very difficult for me to maintain the pace. When you are sitting the exam, you want to do everything fast. At the same time, I have to also cater for the ST1s. So it's a bit of a compromise from my perspective. Having said that, the idea is to finish whole of radiology in the coming few weeks. We will cover all, and we have got courses for all of these, whatever is in the slide. If you see number of hour wise, it's a tried and tested formula for me. You will require about 90 to 100 hours of teaching. We have started with MSK. MSK is the most difficult section from, definitely the most difficult section in FRCR 2B, for the simple reason that you don't see many of these pathologies in your day-to-day practice, but in the exam they expect you to know them. So the idea today was to go through, as far as the curriculum is concerned, I am following David Sutton textbook of radiology. We have covered till here. Please remember that trauma chapters are in our rapid reporting course. So I'm not going to teach you trauma. There will be a separate course for trauma, and we call it the rapid reporting. Today, my mandate was to cover all of this. In this tumor 1 and tumor 2, these are longest chapters, and these are slightly smaller as far as length is concerned. So I wanted to cover all of this, and for this, I require 5 hours. Some of the feedbacks which I got was that 5 hours is a bit too much. Please remember, I'm tuned to teach you for 12 hours a day because of what we used to do. But now I was reflecting on that, and I did reflect that because of Zoom, we have got more time at our disposal. And so I revisited this, and I'm going to give you a I'm going to go for a opinion poll actually today. And whatever you people tell me, then I am going to revamp uh, the today's session and the next session. Let me tell you what is going to happen. Initial schedule was that today, 5 hours teaching, starting now and finishing at 7 o'clock UK time to cover all of MSK, but it might be a bit too much. So the idea is to give you this option, and for this, I want votes from your side. Give you this option to divide it. Today, for example, I can just confine myself to bone tumors, and this will take 3 hours, by the way. It's a very important section, and it will take 3 hours. A lot of concentration is required. And the last bit of MSK, we can reschedule it. Reschedule either on Sunday, which is tomorrow, or Monday, or Wednesday. And it will be in the evening after 5 o'clock. Because on Thursday, we have to start GIT, and this is already in the schedule. Please also remember that next weekend also, I'm going to announce a bit of teaching, maybe 2-3 hours of session, either on 11th or 12th, and this will be again GIT. And another course which a colleague of mine is going to cover is what I call interventional radiology for FRCR, and that I'm going to schedule within next week. If you ask me what my vision now is, actually we are learning every day because it's a new experience, that 100 hours of teaching to be done in only 12 weeks, right? That is the mandate. And for that, we will utilize, after working hours, after 5 o'clock on weekdays and on also on weekends. It is doable, but for those of you who are sitting the exam, they are always very motivated. I'm sure you will do it. Rest of the people might find it a bit tough. But in any case, this course is repeated every 6 months. So we'll do another one in 6 months' time for the next spring course. In any case, now to the opinion poll. Now, if you scan it on your mobiles, and you can see the URL also there. I'll come back to this once again. You will see this. This is a question for you. Should the current MSK Part 4 session be kept as one 5-hour session or split into two? Do you want me to stop in at 3 hours time today versus 5 hours time? And if you suggest that I should split it into two sessions, the second session has to be done either on Sunday or Monday or Wednesday. I'm not giving you Thursday as choice because on Thursday I'm going to start GIT. So if you can please, I'll give you 2-3 minutes to give us your opinion, and my team will then give me the feedback, and I will design the teaching accordingly. So I'm keeping quiet for the next 3 minutes for you. Right, I will continue and start the teaching, and at the same time, my team is going to give me the your responses are coming, so my team is going to give me the feedback about it. Right. So from here, we start the session, and uh, candidate one, can you show your hand, please? Candidate one, can you hear me, please?
Yeah.
Okay, now I want you to tackle this case in absolute details. Suppose you are in the exam, you have got a lot of time, and your description is very important. And all of you, the audience, listen to the description, and then I will teach you on that. Basic idea is, when you get a case of bone tumor, how are you going to tackle it in the exam? What kind of words? What are the pertinent negatives and what are the pertinent positives? So over to you, candidate one.
Okay, so this is a coned-in frontal radiograph of the wrist for an adult patient. There is an abnormality in the distal ulna where there is a lucent lesion with a narrow zone of transition. I can't see any sclerotic margin around the lesion. There's evidence of cortical destruction at the radial side of the lesion with some periosteal reaction also. There's possibly some soft tissue involvement beyond that cortex. Yeah, I think those are the most pertinent findings. Just looking at the rest of the radiograph, I can't see any other similar appearing lesions. So in summary, there is a lucent lesion in the distal ulna with overall, I would say, aggressive features, although there is a narrow zone of transition. In a patient of this age, my primary differential would include a giant cell tumor. Depending on the age of the patient, if they were younger, sort of in their 20s or 30s, I'd also possibly consider. Actually, no, I think that's my only differential.
What is your final conclusion, please?
So my final conclusion was that there's a reasonably well-defined, although aggressive appearing lesion in the distal ulna, and my primary differential would be a giant cell tumor, possibly with a differential of a chondromyxoid fibroma.
Giant cell tumor, chondromyxoid fibroma.
Yeah.
Okay, now let's go to, I'm going to go into a bit of a teaching mode. So candidate one, please bear with me. So I'll teach for a bit and then I'll come back to you once again.
Okay.
Now, if all of you can concentrate on this, aspect of the today's teaching, it is very important. Look at the things on your screen: age of patient, location of lesion, zone of transition, margin of lesion, presence of tumor matrix, pattern of bony destruction, periosteal reaction, soft tissue involvement, size of lesion, monoostotic or polyostotic. The top 8 of them should be considered in each and every case. Because when you start the case in your exam, the first thing which comes to which you have to say, what is the age? The age, the examiner is not going to tell you the age. Age will be indirectly evident because of epiphysis or some degenerative changes or whatever. So you have to tell the examiner what the age is. Location of the lesion is one of the key things and on which we are going to spend some time. And we will come back to this point. Zone of transition is a critical thing. Zone of transition, in your exam, this word should be in your vocabulary. You have to tell the examiner, is it narrow zone of transition or wide zone of transition? If you go into a wrong, world, your differential will completely change. So the point is that these three, the ones in yellow, are extremely important. Then comes the margin of the lesion. So you have to describe the margin. Is there a tumor matrix? What is tumor matrix? We are going to learn. What is the pattern of bony destruction? Again, a bit of vocabulary is there. What is the host response, particularly vis-a-vis periosteal reaction? Is there any soft tissue involvement? These critical things which you have to keep in your mind. Now, other than that, size of the lesion, in some tumors, size of the lesion is important. For example, to differentiate between a osteoblastoma and osteoid osteoma, we will learn, or a non-ossifying fibroma versus a fibrous cortical defect. And similarly, some people think that we are talking about malignant transformation of enchondroma to a chondrosarcoma. Again, size of lesion is important there. Monoostotic or polyostotic, of course, if it is polyostotic, the differential diagnosis will change. So we are going to revisit most of these things in more detail. But before that, a key question in the exam is, which the examiners ask, whenever you get a, what we call, whenever you get a case of a malignant tumor, they will always ask you a few questions. And one of the questions will be, what are you going to do next? What are you going to next means? And some people might say that I would like to do a biopsy or whatever. So please remember that those of you who are participating from overseas, that there is no concept of a biopsy at your center in UK. In UK, there are specialized bone tumor centers. And how radiology is practiced is that if you see a malignant bone lesion, you refer the patient to the bone tumor center. And in the viva, this is what you have to say. Otherwise, you will get negatives for that. And so I work close to London. I'm not in London, but close to London. And here in London, we have got a world famous center, which is known as Royal National Orthopaedic Hospital in Stanmore in London. And you must have, when you were in MBBS, you must have heard about Stanmore hip prosthesis. So this is the biggest bone tumor center in Europe. So we usually just say, I'll refer it to RNOH or to Stanmore, but you can simply use the word bone tumor center. So, and how are you going to stage and things like that? Everything which you want to know for the exam is here on this slide. You will say that I will like to do an MRI, and for MRI, there are the basic thing is for local extension of tumor, sometimes for characterization of tumor also. One of the principles of MRIs, and this is a viva question, what I am elaborating here is that the principle is that the whole bone should be included from joint to joint, at least on one sequence. For example, there is a femur lesion here. So on one of the lesion, whole of the femur should be, till the hip joint should be included. This is usually a T1 weighted sequence. And the viva question is why, and the answer is for skip lesions. We call it skip lesion. There is a main lesion sitting here, but in the same bone, another lesion might be sitting proximally. So this is important to remember. Then for staging purpose, usually RNOH people, they just do a non-enhanced CT chest because tumors usually go to chest, and for that you don't require any contrast. However, because this center also deals with soft tissue tumors like liposarcomas, etc., for that CT chest, abdomen, and pelvis is advised. In any case, in the exam, if you say CT chest or you say CT chest, abdomen, and pelvis, it doesn't matter. Then we do bone scans and bone scan to look for any metastasis. Now things are changing, and some of the centers are using whole body MR. In whole body MR, they do a T1 and a stir sequence. And now a lot of work is also coming up with diffusion weighted scan. So instead of bone, you can do this. And for Ewing sarcoma, PET scan is usually advised. And biopsy will always be at the specialist bone center. This is a key thing to remember for your exam. Now, age of age of the patient is extremely important. And please remember that in the exam, this is a game changer, absolute game changer, because what the examiners are looking for, they want you to tell them the differential diagnosis in this patient. You know, this means the patient which is shown to you in the exam. And if the patient is young, as in this category, look at this difference. You know, this is a chondroblastoma, and the age is first, second decade, or maybe 2.5, maybe till between 20 and 30 is the maximum. But a giant cell tumor, the age goes here till the fourth decade and things like that. So if you get a patient with fourth decade age group and you say chondroblastoma in your differential, that is a blunder. And you are going to be penalized for that. Remember that. So age of a tumor is extremely important. This is from old Chapman, the 6th edition. Now a slight bit of change in the Chapman, but I just wanted to elaborate all of this in one slide. You will get the same information in a different manner. Right. Location of lesion is one of the key things for the exam. Absolutely critical, the most important thing. And we are talking about the long bones here. So, of course, if the type of bone, axial versus appendicular, is a different entity, and there are some tumors which occur at specific bones. For example, in tibia, you might have adamantioma or chondromyxoid fibroma. But this concept is absolutely critical, the most important. What is the location of the lesion within the long bone in a longitudinal axis versus a transverse axis? So in a longitudinal axis means epiphysis, metaphysis, or diaphysis. And in a transverse axis, it is central, eccentric, or cortical. This is, I think, quite recently it was put on Radiopedia, beautifully made. You can have a look, but I will teach you slightly differently. It is absolutely fine to learn from here, but I'll go back to Chapman to teach you. Okay, so I've got the poll results, so let me announce it. Okay, most of you want it to be split. So the decision is made that we will split the session, and today we are going to stop at, when I finish these 2 chapters, maybe 3-hour long session. And then most of you want to do it on, okay, so I accept that also. We will finish it on Monday. So that's my final. What I'll do is I'll announce the dates on the website, sorry, the exact time, etc., looking at my own schedule. So we'll finish on Monday. We might finish it between 2 hours, 2.5 hours, and I'll plan to start at, I'll see my schedule. If I am not working at 5 o'clock, maybe I'll start at 5 o'clock. If I'm finishing slightly late. I might start at 5:30, etc., so that it is finished by about. It's democratic, so apologies to those of you for whom it does not suit, but this is what it is. Now, coming back here is this diagram which has been removed from Chapman in the current edition. Why it has been removed is because there were many mistakes in this diagram, but I used to love it. And I've taught radiology on this diagram for the last 20 years. And the point is that I'm still going to teach you on this diagram, and it is not in the present Chapman. So Chapman, the first edition of Chapman was produced in 1984, and this diagram is from 1981. So to develop your knowledge. And in the exam, my idea is that remember this picture in your mind, and then when you get a tumor in the exam, this picture should be in your mind, and you tell the examiner according to the age, etc., and the location. Now, if you see, this is the epiphysis, this is the metaphysis, and this is the diaphysis. So this is what we call the longitudinal axis. And then is the transverse axis. So this is the medullary cavity. So there will be lesions which are central in the medullary cavity. There are other lesions which are eccentric in the medullary cavity. So they are within the medullary cavity, but they are eccentric. And there are other lesions which are cortical. So they are placed in the cortex. So this concept is critical. And the point is that if you please remember that age will change whatever is present at a particular portion. For example, look here in the epiphysis, you can see chondroblastoma, and you can also see giant cell tumor here. From the previous diagram, we know that chondroblastoma is till age of, let's say, 20, but giant cell tumor 20 to 40. So your differential will change accordingly. So these are the most important tumors as far as epiphysis is concerned. Then comes the metaphysis. In the metaphysis, in the central portion of metaphysis, there is enchondroma. So remember this. This is enchondroma, which is a cartilaginous tumor. And next to enchondroma, they have written chondrosarcoma. What does it tell you? It tells you that there is malignant transformation of the enchondroma, which can happen. And this is what they are going to ask you. I'm going to teach you shortly. So enchondroma can change to chondrosarcoma. But there is another cartilaginous tumor, which is here. And there is a bit of mistake here. The mistake is that this is an osteochondroma, actually. It is not written like this. And this osteochondroma or a cartilage cap exostosis can also malignantly transform into a chondrosarcoma. So when I used to teach on this diagram, I used to tell my students to make a few amendments, addendums. So I'll come back to that. But basically, I recap. In the center of the metaphysis is a cartilaginous tumor, enchondroma, which can convert to chondrosarcoma. In the periphery, arising from the cortex, is another cartilaginous tumor, which is osteochondroma, and it can also convert to chondrosarcoma. Please remember, both of these are extremely important exam cases, and the concepts they will ask you, the concepts. What are the criteria for malignant transformation? Taking it further is this lesion, which is osteosarcoma. Osteosarcoma is a very, very important bone tumor, usually young age group. And look at the location. The location is metaphyseal and it is eccentric. So important point to remember. On the other hand, again, there are mistakes in this diagram. Here, actually, is an aneurysmal bone cyst. So this thing is an aneurysmal bone cyst. And if you can remember it like this, that there is an aneurysmal bone cyst here. I'll continue with this diagram here now, which has got a bit of addendums. Then comes simple bone cyst. So this is a simple bone cyst, and simple bone cyst in the central portion of the medullary cavity. So in the exam, you have to differentiate it. A simple bone cyst, you have to differentiate with an aneurysmal bone cyst. And something which is indirectly placed in this diagram, that the simple bone cyst is central and a aneurysmal bone cyst is eccentric. This is metaphyseal usually. Simple bone cyst is metaphyseal, but there is a concept of migration, which I'll come back to that point. Then look at this lesion. This is fibrous cortical defect. So this is a cortical lesion by definition, and if the size is more than 3 centimeter, we call it non-ossifying fibroma. It can be a lytic lesion, so this can be in the differential, but you can see the location. I repeat, simple bone cyst is central, aneurysmal bone cyst is eccentric, metaphyseal, and the non-ossifying fibroma or fibrous cortical defect is metaphyseal or metadiaphyseal. It can be in the diaphysis also, and by definition it is in cortex, but it can of course come into the medullary cavity. Fibrosarcoma, deleted, it's not for you. Nobody is going to ask you this in FRCR exam. Fibrous dysplasia, maybe metadiaphysia. Look at this lesion here, chondromyxoid fibroma. This is not a very important 2B tumor. Having said that, it's useful to remember it for your differential diagnosis. It's a very rare tumor, and usually it is seen in the tibia. So it's very, each group is slightly different than the non-ossifying fibroma. This age group goes to, let's say, 30, 40 years old, and it is more, cortical and also medullary, and this one is more cortical. So it is, the age will differentiate between the two. There are a bit of fine touch in radiology also. Otherwise, it's not an important tumor. It's not very common tumor. Then comes osteiod osteoma, which is cortical tumor. Adamentoma is a very rare tumor. It can be asked in the exam for the simple reason that it is usually seen in the tibia and in the tibia within the cortex. So in the new Chapman, what has been done is that these diagrams have been changed and one lesion is shown on each diagram. Now, just a revision, look at simple bone cyst and you can see metadiaphysis and you can see central. Adamentoma, it is cortical. Fibrous dysplasia, it is also medullary cavity, but it can also involve the cortex. Ewing sarcoma, which is actually, I forgot to tell you, these 4 lesions here in the diaphysis. Look here, Ewing sarcoma, lymphoma of bone, myeloma, and central chondrosarcoma. So all of these are diaphysia. So this is Ewing sarcoma, osteiod osteoma cortical, osteoblastoma. What is the difference between osteiod osteoma and osteoblastoma? That the nidus is less than 2 centimeter. This is more than 2 centimeter. And chondroma or chondrosarcoma, we know in the metaphysis. Osteosarcoma, metaphysis, eccentric. Aneurysmal bone cyst, metaphysis, eccentric. And then actually, I cannot even read what is here. For me, it's not projected in any case. And giant cell tumor, which is epiphyseal, and a chondroblastoma, which is epiphyseal. So a few examples, and I thank my colleagues from Royal National Orthopedic Hospital who have provided a lot of these images, and I've learned my, all of this bone radiology also from them. So thank you to them. Now, this is an example And you can see that there is a lesion in the epiphysis. This lesion, the epiphysis is, so this is a young patient, and you can see marginal sclerosis. And because the epiphysis is not closed, it's a chondroblastoma. On the other hand, look at this lesion, and it is again goes to epiphysis, and it is subarticular, and this one is a giant cell tumor. Now, this is non-ossifying fibroma, and as I told you, by definition, it arises from the cortex, though it can encroach the medullary cavity. So here on the CT, you can see it here. But radiologically speaking, a non-ossifying fibroma, it can project into the medullary cavity like this, and it can be quite large. Okay, next heading is margin of the lesion. And margin of the lesion is that is the lesion sclerotic or not. Look here, this is a fibrous dysplasia, and this patient has got a thick rind of calcification, which is quite pathognomic for fibrous dysplasia. This one, on the other hand, is a giant cell tumor. Actually, this is the case which was discussed by candidate 1, and this hasn't got a sclerotic margin. Okay, another thing for the exam is very important for you to develop the concept of what we call tumor matrix. Now, there can be 3 types of tumor matrix. One is osteoid matrix, and these are bone tumors, bone-forming tumors which form bone, and that is why it will be a pertinent negative or positive in the exam. So if you see here, there is a lot of ossification in the soft tissue, telling you that this is a bone-forming tumor. And when the examiner is going to ask you, you are going to tackle this case that this is an aggressive lesion and describe it, and then say that within the soft tissue there is osseous matrix. So, and in the conclusion, you say that because this is osseous, this is a bone-forming tumor, and this is in keeping with an osteosarcoma. So the examiner will ask you what is the differential, and you can say that I did consider Ewing sarcoma in this age group, which is not an adult. However, this osseous matrix goes against that. So I'll stick with osteosarcoma. Okay, then comes the concept of chondroid matrix. Now, chondroid matrix is cartilaginous matrix, and within that cartilaginous matrix, what happens is that part of it is only seen on MR, and part of this calcifies. When it calcifies, the bone density is quite high, and you can see it through the bone. So it is very usual for an enchondroma to be seen like this. There might not be any lytic lesion, just calcification. And this calcification, remember, I taught you in the second chapter, 3 words: ring and arcs and nodules. So ring and arc type of calcification is quite pathognomic for cartilaginous tumor, because the differential diagnosis is bone infarcts, where it is geographical serpentinous calcification. So this is chondroid matrix. Chondroid matrix also here in an osteochondroma, where you can see all of this. On an MR, when you look inside a lesion, you can see this lobulated high signal on T2 weighted sequences. So this is important for you to remember that what is the MR signal of chondroid matrix. We will come back to these points when we do cases. And you already know, we have covered it, that fibrous dysplasia can have ground glass matrix, but please remember that fibrous dysplasia, according to the stage of the disease, might be lytic, might be like this, or might be sclerotic. So the next heading is pattern of bone destruction. And the geographical pattern is least aggressive, moth-eaten is more aggressive, and permeative is the uh, most aggressive. So these are examples of geographical bony destruction, simple bone cyst and a giant cell tumor. This, on the other hand, is an example of moth-eaten. Moth-eaten, which is in this diagram, multiple holes. So now you can see it, that these are multiple holes. We call it moth-eaten. Look at this, multiple holes, moth-eaten, and this with periosteal reaction. In the exam, the most difficult one, and many cases have come in the exam in the past from this type of permeative bony destruction. So they will show you cases in which there will be subtle finding. Permeative bony destruction is, though the most aggressive, but most difficult to see radiologically. If you see this, and this is a enlargement, and you can see, look at the marrow, it's not normal, and then there is evidence of periosteal reaction, which tells you that something is wrong. So permeative bony destruction exam cases extremely important. I'll show you cases from this category. You should also have a black and white idea about terminologies of periosteal reactions for your description. This is known as solid periosteal reaction. This is laminated. It can be a single layer. It can be multi-layer, as in Ewing sarcoma in this case. Other patterns, this is a sunburst pattern, and this is hair on end pattern. These are self-explanatory and just for revision. Okay, now it is a good idea, particularly to remember the benign polyostotic lesions. So in the exams, they have come very often, many a times on nuclear medicine studies. For example, they might show you a bone scan, they might show you a PET scan, they will start from there, and there are multiple lesions. And the key thing is for you to ask that I want to see a plain film for correlation. And it might be a fibrous dysplasia, for example, or a Paget's, which can, and histiocytosis is extremely important. This now goes to our Monday schedule. Multiple osteochondroma, multiple enchondromas, all of these things are important. And of course, there can be many, other than metastasis, there can be aggressive polyostotic lesions, as on this slide here. And just to tell you the capability of MRI, that if you get this case in the exam, it's a good case for the exam, by the way. You can see that you don't see anything abnormal, but you do see that there is what we call endosteal scalloping here and a bit of soft tissue. And when you do an MR, you can see that there is an Ewing sarcoma, which has got a huge soft tissue component. In the latest Chapman, you can see all of these things beautifully produced in a tabulated form, and the take-home points are given there. I find them very useful, so I'll recommend that you go through them, and I'll put them in slides also during the session today. Okay, so with this background, candidate one, can you hear me, please?
Yep.
Okay, this is your case, and the patient has got bilateral hip pain, OA. So we are talking, what are your findings? Because of time factor, I will guide you that I want you to see left femur as well as the right femur and tell me the findings in both of them.
Okay, so on the right, there is a mostly lucent lesion with superiorly what looks like a wide zone of transition. I can't see the most inferior aspect of the lesion. It's more centrally placed. There's no evidence of cortical destruction. There's possibly some endosteal scalloping of the cortex more superiorly. At the lateral aspect of the femoral shaft, just inferior to the greater trochanter, it looks like there might be some periosteal reaction.
Here?
Yes.
No, this is just an artifact.
Okay.
Okay, so we'll come back to this. What is
okay.
Here? Because of time factor, I'll give you leading questions, should I say.
So in the left intertrochanteric region, there's a reasonably dense lesion, again with a wide zone of transition. There's some scalloping of the cortex. It's more eccentrically located.
Hint, look at the margin of the lesion. That's the key in this case. Exam key.
So it looks like there's a lucency around.
So we are talking about, where
Yeah.
This margin, how is this margin? Anything comes to your mind?
No.
Okay, I'll take over. Now, if you see here, first of all, is on the right side is an incidental finding. And this is what can happen in the exam. There might be two findings on the same case. If you look carefully, look at these trabeculae. So this is early Paget's disease. This is thickened trabeculae and nothing more than that. So you got confused because of this and that is artifact. So don't worry about that. Now, if you see this lesion, it has got a what we call a brush border type of edge. And this is an extremely important exam case, which has come in the exam quite a few times. Now, develop your eyes of, this is basically a sclerotic lesion. This is the cortex. It is not causing endosteal scalloping. So basically the lesion is sclerotic. And you are talking about what it is. It's a bone island. And the key finding is that in a bone island, what happens is, look at this from stat dx, and these three things you have to remember. Dense bone fades out at periphery and they merge into normal trabeculae. They merge into normal trabeculae and brush border edge. So brush border edge is this. It's a key finding, which even here in your case, you can see this brush border edge. So bone island has come in the exam, and this thing is what helps you. Bone islands in your day-to-day radiology are also seen incidentally, let's say in a CT scan. At times it's difficult. But again, if you see it carefully here, you can see this brush border edge. And here you can see this pedicle, and there was some sclerosis here on AP view. Bone islands can also mimic something more significant, where they can show some uptake on a nuclear scan, and this CT scan shows that. So take home point is brush border edge in a sclerotic lesion. Okay, candidate one, over to you, please.
Okay, so these are frontal and lateral radiographs of the tibia and fibula for a 21-year-old patient. At the anterior and medial aspect of the mid-tibial shaft, there is cortical thickening. Sorry, I'm just trying to zoom.
That's fine. And I'm sure you in the exam you will be here. You are handicapped because I'm showing you in a PowerPoint manner. So you have picked up cortical thickening here. And do you see anything within the cortical thickening?
On the lateral view, that looks like there's some more high density areas, possibly some lamellated periosteal reaction.
Okay.
I don't know if
So
that's
this is
projecting
what
right.
we call the solid periosteal reaction, right? You remember I showed you a few examples, and this is known as a solid periosteal reaction. Now, give me a bookish answer, not in this case, but if clinically speaking, if a young patient like 21-year-old comes to you with this kind of symptoms with tibia, what is your differential diagnosis?
So I think given the size, possibly an osteoblastoma. It's more centered around the diaphysis.
Okay, good. So you are talking about either an osteoid osteoma or a osteoblastoma. What else other than a tumor?
Could it also be post-traumatic change?
And which kind of trauma? Chronic trauma, repetitive trauma, as in a stress fracture. In a young age group, please remember this is a very important concept that in tibia, for example, cortical thickening. So the main differential is an osteoid osteoma. Osteoblastoma, of course, is a bigger version of osteoid osteoma, and then a stress fracture. Now, coming back to this case, you have picked up solid periosteal reaction here. What will you do next? This is my question.
Would you consider further imaging with a CT?
And how will CT help you?
So if it is an osteoblastoma, then it should show you whether there's possibly a nidus within that sclerotic area.
Okay, very good. In this particular case, initially a nuclear scan was done, and the nuclear scan is not helpful. And this is a key exam point. Don't ask for a nuclear scan because a nuclear scan is a sensitive tool but not specific tool, and it shows uptake, and we are where we were. Uh, and on a CT scan, now I'm showing you this CT, just a single. What is your final conclusion on this CT? Over to candidate one.
So the findings on the CT would support a diagnosis of osteoid osteoma with a solid cortical thickening with a central lucency in keeping with the nidus.
Okay. So please remember, in the exam, I think this is the only osteoid osteoma for the exam is the only scenario where you are going to ask for a CT, because otherwise in a bone tumor you ask for an MR for characterization, etc. Why CT here is that CT is much better to characterize or show you the nidus or a fracture line of a stress fracture than an MR. I'm not saying that the same thing cannot be seen on MR. At times it can be seen, but many a times it is not visible. So you'll ask for a CT. And osteoid osteoma peak age is 10 to 30 years, and lucent nidus, which is less than 2 centimeter. If it is more than 2 centimeter, then it goes to osteoblastoma. In the differential diagnosis of tibia, there is another thing which can be added, but this thing is not for your FRCR exam. In your clinical practice, yes, we used to use the word shin splints for this, but now we use the word medial tibial stress syndrome, where you can see that along the periosteum there is a bit of edema. So these are the top 3 differential diagnoses in this clinical context. This is another case of osteoid osteoma where if you see here, you can see this solid periosteal reaction. You don't see anything. You do a CT scan and you see this nidus and this cortical thickening. The nidus itself can be either completely loosened, remember this, and sometimes within the central portion, there might be sclerosis. So it is one and the same thing. This target type of appearance can also be seen. This is a case of osteoid osteoma, where you see this is the nidus on MR, but you can see this bone marrow edema is also high signal, and there is high signal here also. Okay, candidate 1, 17-year-old hip pain. Can you guess which side is the hip pain? Indirectly, I'm asking you which side is abnormal.
Left.
The left. And why do you say that?
So it's asymmetrical in that there's thickening or expansion of the femoral neck.
Okay, I'll show you
region.
Close up. Good, well done. Please continue.
So within that, there's a lucent lesion at the inferior aspect with some.
You're talking about this aspect?
Yes.
Okay, look somewhere here, please.
Okay.
The quality of the film is poor, so don't worry, because it's projected very faintly. Anything you can see here? Stretch of imagination. You are in osteoid osteoma.
So there looks like, is there some soft tissue or like disruption of the fat planes around that?
Okay, so you have picked up effusion. Well done. Well done.
The whole sort of femoral neck appears more radiodense.
Okay. Now, if you see here, what is happening, that look at, and this is a classical exam case, and why it is a classical, I will tell you. Because the osteoid osteoma is sitting here, I'll show you, that might be difficult, but you pick up this cortical buttressing where you can see this thickening here versus this. If you proceed further, this kind of case will have lot of, so this is a posterior view, and lot of uptake on a nuclear scan, even on the other side. Basically, what happens is that this is what we call the intracapsular osteoid osteoma. So this is within the capsule, and this is favorite for the examiners. And if you go back to the anatomy, it is within the capsule of the joint. It can be loosened with a sclerotic center, though it might be on a CT scan. This one projects like this. There is effusion, just like you picked up. That was well picked up. There is cortical thickening here. And your case, this was the osteoid osteoma, but it is causing so much of reaction because it is within the capsule. This buttressing is a main thing. And in your case, though the film quality is poor, but you can see that there is a bit of lucency with this target sign. On a CT scan, it is sitting on the surface. And on this one also, it is sitting on the surface, and this is more bubbly. So this is intracapsular osteoid osteoma. Your last case, please. So I will guide you. This is a 28-year-old female, came with backaches. These are the stir sequences, just limited sequences of the stir. This is L5, this is L4, L5, L4. Something is happening here. People did a nuclear scan also for some reason. There is an uptake here. What do you think is happening? Over to you.
Okay, so there's, on the selected sagittal MRI slices, there's high stir signal in the pedicle of L4, which I think on the axial correlates to the right pedicle, sorry,
Yeah.
and also some increased T1 signal. Also, there's selective uptake in that pedicle on the bone scan. In a patient of this age with a history of back pain, these appearances would be in keeping with an osteoid osteoma.
What is your differential diagnosis?
It could also be post-traumatic change, so maybe like a pedicle fracture.
So which kind of pedicle fracture again? You
Like a
remember?
pars defect, sorry.
Yes, pars defect. So please remember, just like your tibia here, the main savior for you is the CT scan. And this is another scenario in your exam where you're going to ask for a CT scan. And on a CT scan, again, you can see that there is a nidus sitting here. And because osteoid osteomas do occur in the spine very commonly. So remember CT scan in osteoid osteoma, another one sitting here, and this is where it is sitting. But on CT, it is very well seen. Okay, I am going to give you a break in 5 minutes time. I'll continue with yourself. So what is this? Over to you.
So this is a frontal radiograph of the lumbar spine for a 17-year-old patient. There's the pedicles of the L2 vertebral body are not clearly seen. They appear more sclerotic, particularly on the left.
So this is the L2, and this pedicle you have pointed out. What's happening to this transverse process?
That's also more dense and quite expanded.
Yeah. So what is your conclusion? What can it be just on the basis of this plain film?
So I think in keeping with the appearances, it's most likely, and given its size, it's probably an osteoblastoma rather than osteoid osteoma. It looks like it's more than 2
What do you
centimeters.
think now on the CT scan? What is your conclusion?
So it's an expansile lucent lesion with quite dense sclerosis around it. I still think that an osteoblastoma would be a differential diagnosis to consider, but it could also be an ABC.
Right. What will help you to discriminate between the two, osteoblastoma versus an ABC, aneurysmal bone cyst?
I think an MRI.
Okay, we'll come back to that. But okay, now you have to develop your eyes, the difference between an osteoid osteoma versus an osteoblastoma. Now, what happens is that in a osteoid, if the nidus is more than 2 centimeter, you call it a osteoblastoma. When it is sitting in the pedicle, in the posterior elements of the vertebra, you can see sclerosis. And sclerosis of the pedicle is more prominently seen in an osteoid osteoma instead of an osteoblastoma. It can be seen in an osteoblastoma also, but because the nidus is lucent, so that is why a denser pedicle might be visible on an osteoid osteoma. Now, in this particular case, you can see that there was expansion of the transverse process with a lucency. This pedicle is not very well seen. It's not classical sclerotic. And here you can see that just concentrate on the pedicle. This is the pedicle, this is the pedicle, agreed that this is thickened and agreed that this is sclerotic. But what will offset this finding is that the nidus itself is lytic. So on a plain film, it will not be as sclerotic overall as if it was just an osteoid osteoma. So in your book, if you see here, solitary dense pedicle, this is 2.5. Osteoblastic metastasis, they have come in the exam very often. Osteoid osteoma, I've already shown you a bone island. But if you read the text underneath the osteoblastoma in the current edition, they have said the same thing which I've just told you, that osteoblastoma can also be sclerotic, but because of the lucency, the finding is not all that marked as in osteoid osteoma. So this is from the book, and the main thing is that the nidus is more than 2 centimeter, and this is an osteoblastoma from literature, and this is a long bone. They will not show you usually osteoblastomas in the long bone. They will show you osteo what we call in spine. And another example where you can see that this pedicle is visible, but then you can see that there is expansion of the transverse process. So this is another case of osteoblastoma. Can you describe this case? This is a case of osteoblastoma. Can you describe it? What is happening?
So on this lateral C-spine radiograph for a 20-year-old female, there's a reasonably large expansile lesion in the spinous process of the C2 vertebra. It looks like it's causing some remodeling of the C3 and C4 vertebral spinous processes as well.
So what is your differential?
So my differential would still include an osteoblastoma. Could also be an ABC, although
Yeah, that's fine. So you can mute yourself. Well done. Now, the take-home point is that irony is that osteoblastoma is a bone-forming tumor, but the nidus itself is because it is lucent. In the spine, the differential diagnosis is with an ABC, aneurysmal bone cyst, and it can be as big as this, and it can be something like this. And when you do MR will there will be a what we call fluid level. Look at this case from literature. I'll show you more in the next chapter, where you can see that there is a lesion here, and you can see how it is causing expansion. And this is the picture, the graphic of ABC. And when you do an MR, you get this fluid level. So the correct answer, as the candidate pointed out, is that I'll do an MR, and on MR, I can get fluid levels to differentiate between an osteoid osteoma versus a ABC. Of course, other thing like bone matrix and things like that, you can also, because you remember that pedicle which was thickened, which was sclerotic. So that is another example. Now, in this particular case, this is another example where a osteoblastoma is causing expansion of the transverse process. This is another example. And you will agree that in this particular case, the lucency is not complete, and there is a bit of osteoid matrix. So this you will not, you should not confuse it with an ABC. But if it is completely lucent, of course, then you might confuse it with an ABC. And so this is another case where you can see the graphic sitting here, and from literature, another example, lucency bit of osteoid matrix. If you see osteoid matrix, you're very confident that this is a osteoblastoma. And if this thing was smaller than 2 centimeter, it would have been an osteoid osteoma. So we stop here, and this is a 5-minute break. So we will continue, and candidate 2 will raise the hand. It should be ready after the break. I'm going to mute myself for the next 5 minutes. There's a feedback here. You can
located in the medial cortex of the left proximal tibial metaphysis. There is osseous matrix and an aggressive periosteal reaction. There's possibly some irregularity of the cortex, and although there is some cortical irregularity indicating cortical destruction. And the lesion appears aggressive, and the differential is of osteosarcoma, or less likely Ewing sarcoma.
And why less likely Ewing sarcoma?
Because of the location within the bone.
And number one.
Sorry, and also because of the prominence of the bone-forming nature of the tumor.
Yeah, so this is critical here in this particular case. There is a black and white, what we call bony matrix, which is osseous matrix. And here the examiner is going to check your thinking. You can see the osseous matrix has also gone into the soft tissue. You can see all of this sclerosis. So because of that, you have to be more confident and emphatic that this is it, and this is in keeping with an osteosarcoma. Another case of osteosarcoma, just I'm showing you multiple examples just to develop your eyes, where you can see this osseous matrix, and then you can see this some soft tissue, and look at the zone of transition, which is widened. Another case of osteosarcoma, and this one is in fibula. And why is it an osteosarcoma? Because of this sclerosis, which is osseous matrix. But remember that we learned that osteosarcoma is what we call metaphyseal, and it is eccentric, like previous cases. You see, this is eccentric. What happens in the narrow bones in fibula as well as ulna, that the classical teaching of eccentric versus central does not hold true, and these kinds of cases will confuse you always. I'll show you more, where in a narrow bone like fibula or ulna, the principles, for the simple reason that there is not enough place within the medullary cavity, so it will appear more central. Another case, sorry, this is the same case, and just to show you on a lateral, you can see this, Heronin type of periosteal reaction. Again, in the description, how will you describe this?
So the lesion is centered in the left proximal humerus. It has dense, irregular osseous calcification within, consistent with an osseous matrix. There's an appreciable soft tissue component to the lateral aspect, and in the same region there's periosteal reaction. And again, a wide zone of transition.
Right. And always, look for any soft tissue. Within the soft tissue, if there is an osseous component, call that, because that's a key finding for bone-forming tumor. Osteosarcomas can also be diaphyseal. And this is a subtle case where along this, there is a bit of periosteal reaction. Now, look carefully and you will agree that there is some osseous matrix within the soft tissue. So this is a diaphyseal osteosarcoma. Previously I have told you when we were considering infections that in the exam, always use the word initially in your description, you have to say an aggressive lesion, because differential diagnosis wise, infection might be in the differential. Don't use the word a malignant tumor in your description, and in your conclusion, of course, you can conclude it as such. Okay, over to you.
Frontal and lateral radiographs of the knee and proximal calf of a 17-year-old patient. There's a gross abnormality which appears to be centered on the proximal tibial metaphysis, but is extending outside the bone with dense osseous, dense calcification. I wonder whether this is chondroid or osseous in nature. But other factors that I'm evaluating include the zone of transition, which is wide. There's evident soft tissue component. So this looks like an aggressive lesion, most likely an osteosarcoma.
Okay, so you described it. Some debate came to your mind as far as chondroid matrix versus osseous matrix. Can you revisit that? What were you considering?
Well, just in parts of the lesion. So, for example, on the frontal radiograph, the infromedial aspect, there are some. The calcification appears somewhat septated or ring and arc-like.
Mm-hmm.
So I just wasn't sure how best to classify this matrix, and if it classifies as one or the other, then we have to consider whether this is a malignancy of chondral origin.
Mm-hmm. Right. So the point is that this is an aunt mini case, very important for the exam. And aunt mini cases are, if you see them, you are never going to forget them. And if you don't see them, you are always going to be very confused. This is a par-S osteal osteosarcoma. Now, in par-osteal osteosarcoma, what happens is that this arises next to the periosteum. It goes into the cortex also, but then it sort of continues growing around the bone. Look at this CT scan, and this tells you, and this is osseous matrix. This is classical osseous matrix, not cartilaginous matrix. And in the case which I showed you, what is happening is that there is so much ossification that it has gone all the way around. And if you come back here, you can see that it has gone all the way around. It's quite a unique type of an appearance. As I told you, it's an aunt mini case. If you have seen it, you are not going to miss it. If you have not seen it, you will be, struggling. A sign which is given is that at times, part of the lesion and the cortex, there might be a lucency, which is visible here. So this is par-osteal osteosarcoma. Now, in your Chapman, there is a 4.3 soft tissue ossification. There is a difference between the word ossification and calcification. And here, what is happening is that par-osteal osteosarcoma is given as one of the differential. Osteosarcomas can have metastasis within the bones. There is a bit of discrepancy in literature. Some people use the word multifocal osteosarcoma. And the second concept is that osteosarcomas which has metastasized to the bones, multiple bones. And this is an example where this was the primary lesion, and you can see metastasis in other bones. osteosarcomas, and this is those of you who are sitting your 2As, classical 2A question. Osteosarcomas, pulmonary or pleural metastases are there, and it will cause pneumothorax. So, and this has come in the exam many a times. They will show you a chest X-ray with pneumothorax, and there might be a ossified, metastasis sitting there, meaning that there is an osteosarcoma, and you will be grilled on the concept of that. So remember that. And also, osteosarcoma metastasis rarely, very rarely, can be in the soft tissue. This is from literature. So it's a very rare thing to happen, but this is an exam phenomenon. Okay, from here we come to another world, and over to you, candidate 2.
This is a DP radiograph of a 42-year-old male's right hand. Is it a 42-year-old male? It's an unfused.
Oh, that's a typo. So I apologize for that. Well picked up.
So 12 potentially, or something of that ilk.
Yeah, I think so.
There is an abnormality of the right index finger proximal phalanx, which contains within the distal aspect of the diaphysis a well-defined lucent lesion with a thin sclerotic edge that contains some internal matrix with calcification. There's no soft tissue component, no cortical destruction, no significant deformity. It's not particularly expansile. The appearance of this lesion is mostly given with an enchondroma. It has benign appearances.
And what is your differential?
I suppose it could be another benign lucent bone lesion, potentially a bone cyst, although I wouldn't expect internal matrix in that case.
Excellent. Okay, I'll take over. Well done. So if you see this lesion, there is basically a lytic lesion, right? And a lytic lesion with which has got a narrow zone of transition, and the differential diagnosis can be quite extensive, which many things can be considered. But simple bone cyst, aneurysmal bone cyst, whatever, chondroblastoma, not in this particular case, but at times it can happen when it goes to the epiphysis. Langerhans cell histiocytosis, considering the age. So many things can be considered. But the key finding here was that chondroid matrix. So this is an enchondroma with chondroid matrix, which is punctate calcification. So the take-home point is that that has made the whole of the differentiation. And if an examiner shows it to you, he or she is going to sort of ask you questions so that you reach a specific diagnosis. Thinking is what is your thinking? This is what they are looking for. So this is an enchondroma. Enchondromas can occur in the short, 50% of them are in the short bones, particularly hand. And you will get a lucency. You might get chondroid matrix or might not get chondroid matrix. So remember that both type of pictures can happen. At times you will get with a fracture like this case. So both types are sort of possible in the exam. One special type of enchondroma, which I'm showing you here, and then I'll show you the exam cases. But if you have this concept, only then you will understand what happens. This is a type of enchondroma, which is known as enchondroma extuberans. So it arises from the cortex and it can grow outwards. So the basic concept, you remember that we learned the basic concepts that enchondroma is in the medullary cavity and it is central. But if you know that there can be enchondromas which arise from the cortex. Why? I'll tell you why. Because in Ollier's disease, etc., you can get these kinds of lesions. Now, candidate 2, over to you.
This is a frontal radiograph of the right index finger of a 35-year-old female patient. There is an abnormality of the right index distal phalanx, which is essentially the entire medullary cavity is occupied by a lytic lesion without particular evidence of expansion or cortical destruction, but there is a transverse lucency through the inferior, the proximal aspect, suggesting a fracture through this. So the overall appearances are of a pathological fracture through a bone lesion. The lesion itself has benign appearances and may represent an enchondroma or potentially a simple bone cyst.
Okay. Here, I'm showing you a MR, and on this MR, we can see that there is high signal within it. It is sort of a chondroid matrix. In any case, we'll come back to this chondroid matrix. Now, spot diagnosis candidate 2, can you just name of this disease? Mini case.
Ollier's disease?
Ollier's disease. In Ollier's disease, what is happening is that there are multiple enchondromas, and they can be within the medullary cavity, and they can be, that extravagant type. And and there can be other cartilaginous abnormalities also. There is a rate of malignant transformation in literature, and there is a bit of controversy about the rate of malignant transformation. But having said that, Ollier's disease should be, you should just know that what is Ollier's disease, and they might show you a case with malignant transformation. Okay, this is a very, very good case, and classical exam case. Over to you. So all of you should concentrate on this case.
So these are bilateral frontal radiographs of the hands of an 11-year-old male patient. There is a multifocal polyostotic disorder with lucent bone lesions that contain chondroid matrix in many of the metacarpals and phalanges. These appear to be multiple enchondromata, and I suspect that the patient has an underlying condition such as Ollier's or Maffucci syndrome. I would evaluate
Maffucci syndrome, please.
Sorry?
What is Maffucci syndrome? You just said Maffucci, so what is Maffucci syndrome?
So I believe it's the coexistence of multiple enchondromata with vascular malformations. And one thing that I would look for is obvious soft tissue abnormalities or calcifications within a slow flow vascular malformation to suggest that diagnosis. Excellent.
Do you pick up anything in this case?
There is a soft tissue calcification adjacent to the left ulna, right ulna.
Yeah, so this is what we call a phlebolith, and it's a key finding. This phlebolith changes everything, and in the exam you have to pick that up. This is sort of a evidence that there is a hemangioma sitting there, one of the vascular tumors which can happen. In this particular case, if you see, this is 11 years old. This is at the age of 18, and how it has grown. And these patients at time might have amputations in the interval and things like that because of surgical, it will be very difficult to carry this finger. Having said that, if you see that this finding, and you can understand now multiple phleboliths are there, and there is scalloping, and this scalloping means that something soft tissue tumor is sitting there. Now, in literature, the controversy is that in Maffucci syndrome, some of the studies say the malignant transformation rate is between 23% to up to 100%. So this is a controversy, but in some of the studies, they have proven that 100% rate of malignant transformation, which is so huge a number. And usually these are soft tissue, angiosarcomas or hemangiopericytomas and things like that, those tumors which develop in these patients. Spot diagnosis. What is your diagnosis?
It looks like an enchondroma of the right proximal humor.
Right. So enchondroma. Now, if you can make a note of what I am going to teach you right now, I'll just, if you got a pen and pencil, these are take-home points. They will show you enchondroma in the exam, which with signs of malignant transformation. Classical viva questions will be where the examiner is going to lead you, is there malignant transformation or not? The theory behind it is that enchondroma in the long bone, you might not see any lucency. Enchondroma in the short bone of the hands, for example, you will see lucencies, right? Here you might not see. The only key is the chondroid matrix, which is classically defined as ring and arcs and nodules, right? And as I told you that if it is serpiginous, then that is a bone infarct. That's different radiology. Now, classical viva concept is that if a patient develops pain, pain is taken as a sign of malignancy, right? Number one. Number two, comparison with old film. This is a viva scenario where you are going to ask the examiner, I want to see the old film. I will compare it in my day-to-day practice. I will compare it with the old film, because if there are changes there, sometimes if there is malignant transformation to a chondrosarcoma, the chondrosarcoma might become dedifferentiated and the calcification might not be visible. It will be eaten up by the malignant cells. So the point is that that is number two. I will like to compare it with the previous films. Then when you see a lucency inside, that lucency will cause end ostial scalloping. And that scalloping is going to, if I show you a case right now, and then we will come back. Now, concentrate on this case. This is a lytic lesion, and what it is doing, it is causing scalloping of the cortex. So our criteria is if the end ostial scalloping is more than 2/3 of the thickness of the cortex, then it is taken as a sign of malignancy. Another criteria, if the scalloping is more than 2/3 of the length of the lesion, you see this is the length of the lesion, and if it is more than 2/3, and of course in this case all of this is scalloping, here there is less scalloping, here there is more scalloping, so this is a development of a chondrosarcoma. And third thing is MR criteria. On MR, remember that cartilaginous matrix has got high signal, lobulated high signal. If you lose that lobulated high signal, that is taken as a sign of malignancy. But do not confuse it with calcification. The calcification will also be low signal. And some people use contrast, and what they do is they give contrast and they correlate where there is loss of high signal in the same region. If there is enhancement, that is also taken as a sign of malignant transformation. So these are the concepts. But Royal National Orthopedic people, they do not use contrast. They say that we can diagnose it just on the basis of the regular sequence. So I repeat, viva questions: pain. Number two, comparison with old films. Number three, scalloping, which is more than 2/3 of the thickness of the cortex. Number four, If it is more than 2/3 of the length of the cortex, next on MR, loss of lobulated high signal on T2 weighted sequence, and on contrast if there is enhancement in the same area. Another criteria which is used is a lesion which is more than 5 centimeters. So these are the criteria, and these you should know for your exam. Having said that, we come back to the case where we were. Okay, this patient, over to candidate 2. I will.
Yeah.
So this case has got chondroid matrix. The patient has developed shoulder pain, and the patient came over, and somebody did a nuclear scan, and it shows uptake here. What is your conclusion?
I'm not sure that the presence of uptake is particularly helpful because the underlying benign lesion might well take up tracer.
Excellent. So that's the key, and this has come in the Viva also. Please remember that up to 30 to 35% of enchondromas can show uptake on nuclear scan. This is not taken as a sign of malignant transformation. Indirectly, nuclear scan hasn't got the specificity. The same case, this is a T2 weighted sequence. And if you see here, I'm just showing you this just to develop your eyes. On this T2 weighted sequence, may it be a PD fat saturated sequence or a stir sequence, you can see this lobulated chondroid matrix. And on an axial slice, you can see this lobulated, and you can see the cortex which is thickened. So within that, where there is low signal, that is calcification. So this is normal chondroid matrix. And incidentally, you will pick it up very often in your day-to-day reporting, where in an MR, you can see it here, you can see it here, and calcification, you can see here, incidentally speaking. Okay, candidate 2, this is your last case. And candidate 3, please be ready for your next. What is your spot diagnosis? Just give me the diagnosis, very easy case.
Osteochondroma?
Osteochondroma. In osteochondroma, what happens is that there is what we call exostosis, cartilage cap exostosis. This is the cartilage cap. And the Viva questions will be about malignant transformation. So the concept is that when there is malignant transformation, the patient might develop pain. So again, the same thing, but the counter argument is that this pain might be because of mechanical factors. Key concept is that if the cartilage cap thickness increases, that is taken as a sign of malignant transformation. So literature tells us there is a bit of difference between a growing skeleton and an adult skeleton. In a growing skeleton, anything less than 1.5 centimeter is taken as normal. In an adult skeleton, less than 1 centimeter is taken as normal. In a growing skeleton, between 1.5 and 2 is a gray area. In an adult skeleton, between 1 and 2 is a sort of a gray area. More than 2 centimeter is taken as a sign of malignant transformation. And I warn you that there is a bit of discrepancy in literature. Some people think more than 2.5. But having said that, with this concept, the Viva questions or the exam films which will come to you, you have to measure this and tell the examiner that this is thickened. So if you see here, this is an osteochondroma, and in an osteochondroma, cartilage cap exostosis. So there is a bone component which merges with the cortex of the bone, of the parent bone. It grows away from the joint. So this is a classical appearance, and this is the cartilage cap. All of the action is at the cartilage cap. Now the cartilage cap, if you look carefully in this case, here you are, this one is the cartilage cap. You don't have to measure it, and in this case, it is definitely less than 1 centimeter in thickness. Now, osteochondromas are various types, and this is a sessile type. Just wanted to show you so that you don't get confused if you see it. And osteochondromas can be in the spine, and they can cause a lot of problems. You can well imagine how it will be compressing the cord, etc. This one. Okay, this is an exam film. Candidate 3, can you raise your hand, please? Thank you, candidate 2.
Hi.
Okay, so candidate 3, this patient has got an osteochondroma. We know that. The patient has presented with pain. They are worried. What will you do?
So I would compare with any previous radiograph to see if there's any growth or change.
There was nothing, nothing significant there.
Okay, and I would look at both projections to make sure there's no pathological fracture.
There was nothing.
So my next step will be an MR to evaluate the cartilage cap.
Over to you. This is the MR. Of course, you are not on Osirex or a PAX. You cannot measure it, but eyeballing it, what do you think?
So it appears to be larger than 2 centimeters.
Oh, thickness, not larger. You see the thickness, this is the long axis. If you see from here to here is the thickness, from here to here is the thickness, here to here is the thickness. And we are talking about thickness, this and this. This axis we are not bothered. Thickness, the bone is here and this is the cap. So if I go back and you see this is the cap. So we are just talking about the thickness, and this thickness is less than
2 centimeters.
1 centimeter.
1 centimeter.
Yeah, and this is a benign lesion, so there is no malignant transformation. I repeat, less than 1 centimeter means it's a black and white benign. More than 2 centimeter, it means that it is malignant, and in between is a gray area, because even if you don't have to remember, growing skeleton and an adult skeleton, you just remember it like that. And please remember, if it is a gray area in the exam, you have to tell the examiner, I want to measure it. So, of course, if he or she wants you to measure, they will let you measure on PACS, on the software, I mean to say. But otherwise, they might tell you that this is it. What do you think? Because at times they don't have time and they want to carry on. So please remember, if it is a gray area, even what will your next Viva question? What will you do next? And the answer is, I am going to refer the patient to RNOH or a bone tumor center, whatever you want to call it. So another case where we have got an osteochondroma and had increase in pain. So we have done this MR. Over to you. What do you think?
So I'm provided with an axial T1 image and a stir sagittal image. The lesion appears to be high signal on stir and intermediate signal on T1. The cartilage cap appears to be thickened in this situation, in this case.
Excellent. And your conclusion?
So I'll be concerned about malignant transformation to a chondrosarcoma.
Excellent. And what were you going to do? Send the patient to?
I will send it to a local sarcoma center.
Excellent. So if you see here, this is the cortex, which merges with the cortex of the parent bone. From here to here, this high signal is the key on T2 or PD or STIR, whatever sequence. And this is all the cartilage cap. It is thickened. Spot diagnosis without wasting any time.
Multiple hereditary exotosis.
Excellent. This condition is multiple hereditary exostosis or multiple osteochondromatosis, also known as diaphyseal eclasis, right? And we know that there can be multiple osteochondromas. Another case here, it's a sort of an aunt mini. The only case you should be worried about in the exam is with malignant transformation. They will show you a case in which there is malignant. There is a bit of discrepancy in literature. Some people think up to 10%, and there are other studies also. So there, they will show you cases in which there is malignant transformation. And if you see, this is a type of case you should expect in the exam. This is from literature where this is a story film. And in FRCR exam, these kinds of cases are very favorite of the examiners. We call them a story. It tells you a story. Multiple, osteochondromas with that a surgical defect. So you have to make the story. Means that there might have been a malignant transformation and they have removed that. Yes, please, over to you.
So this is a frontal and lateral radiograph of the right knee in a 13-year-old male patient. There appears to be increased sclerosis in the proximal tibial epiphysis with what appears to be a central lesion. The lesion is fairly lucent, has a narrow zone of transition. There's no associated periosteal reaction or soft tissue components. Overall appearances are with a non-aggressive lesion, and a chondroblastoma will be the top of my differential.
Can it be a giant cell tumor?
No, it's the wrong age group.
Excellent. So you see, because the age group is different, giant cell tumor is more than 20 years, 20 to 40. So you will not call it. So of course, there is a differential diagnosis, which is, so what is chondroblastoma? Age is 5 to 20, and it is an epiphyseal lesion. So now this is an extremely important differential diagnosis for your exam. One of the top differential diagnoses for MSK. And you have to really, this comes in the exam, so many aspects which can come in the exam. So I will tell you a few points for the exam. Lucent epiphyseal bone lesions related to joint. Geode has come in the exam. PVNS is extremely important for the exam, and yes, last time we saw that. Giant cell tumor, of course, non-sclerotic margin, mainly in adults. Chondroblastoma, typically 10 to 20 years. You see, this is the discriminator. Brody's abscess can happen. Now, location-specific lesions. Now, this is very important for the exam. All these tumors have come in the exam, all of them. Please remember, in the carpal bone or tarsal bones, the word epiphysis, they have got the same epiphysis. The bone itself is the epiphysis, right? So intraosseous lipoma, location-specific lesions. Intraosseous lipoma, where? Calcaneum. So this is exam case, and I'll show you today. And in that, there is central calcification. On the other hand, a simple bone cyst can also happen in calcaneum, and there is no central calcification. Look at the discriminator. Osteoblastoma, classical location talus. So at times osteoblastoma can occur in talus also. I've not shown you till now. I'll show you in the next chapter. This is a rare tumor, clear cell chondrosarcoma, I believe beyond 2B level. These things are extremely important. Bone lesions which can occur anywhere. Things like brown tumor of hyperpara, metastasis, lymphoma, hemophilic pseudotumor. And I think you can add here Langerhans cell histiocytosis, LCH, which we are going to cover. Another case of chondroblastoma, where you can see that there is a subarticular lucent lesion with sclerosis. And because of the location, that is what it is. Another case is here. This is just for completion's sake, this is a case of chondromyxoid fibroma. You remember the diagram which I showed you? It was there. It is, the classical location is tibia, and it is slightly eccentric, and it has got a narrow zone of transition. The age group is not like non-ossifying fibroma. The age group is slightly more. So I've just shown it to you for differential diagnosis. Otherwise, it's not an important tumor. It's a very rare tumor. So, but you might like to, if, for example, you are shown a case of non-ossifying fibroma, which I'm going to show you in the next chapter, and the examiner is asking, what is your differential? Then you can consider this and rule that out, because the age group is different and radiology is a slightly different also. Okay, candidate 3. This case has got increasing right arm and shoulder pain. So we did a X-ray. What are you going to do? First step.
So I would compare with any previous imaging that was available.
Excellent. In this particular case, we did not have any previous shoulder X-ray, but we had a chest X-ray. Luckily, that part of anatomy was covered somehow or the other. This is 4 years old X-ray. So this is 4 years old, and this is current. Any observation? 2010 versus 2014. Any observation?
So it hasn't changed very much. It appears to be geographic and medullary in appearance and may represent a bone infarct.
You see, if you look carefully, rings and arcs are there. So it is an chondroma. But having said that, if you look carefully, there is a bit of lucency, stretch of imagination, a bit of lucency here. And though it might be difficult for you because the projection is not the same, this lucency was not present. So comparison of old X-ray, one of the aim is to see is there any difference. And what happens is when chondrosarcomas develop, they start, I just remember it like this, they start eating up the calcification if it is a dedifferentiated type. So this lucency should raise eyebrows. There's a difference. There is a difference between old and what are you going to do next?
MR.
On this MR, I don't have any axial sequences to show you, but just to help you, look at this sagittal. This is lobulated cartilage, and bit of calcification. Do you see this bit here, right? This slightly different. It's not a very good example to show you for the exam, but it's a real life example. So I'm showing you, actually this correlated with this, and this proved to be a chondrosarcoma. So take home point is that you have to, when you compare with the previous X-ray, this is something which you have to pick up. This particular case is more for teaching than for the exam. Otherwise, it's not a very good quality for the exam purpose, I mean to say. This case I have already explained to you. I don't have a old X-ray for this, but hypothesis is that there was a bit of chondroid matrix, and now everything has been eaten up, and this endosteal scalloping and the involvement of more than 2/3 of the length of the bone is what we are talking about. So this is a chondrosarcoma. And if you see here from literature, so this kind of case again can come in your exam, and you can see this lucency. This is the endosteal scalloping. And on MR, you can see a bit of enhancement, and this lesion has gone out. So please remember that sometimes cartilage will still be visible because it might be not be a dedifferentiated chondrosarcoma. It can be, there's a spectrum there. So there can be cartilage, and even then it can be malignant. This is a chondrosarcoma arising from an osteochondroma of the pelvis. And chondrosarcomas can occur in the pelvis also. Here again, the chondroid matrix is why I'm showing you this case, quite non-specific. There is a lucent lesion, and with that, there is chondroid matrix. So I just wanted you to develop your eyes on chondroid matrix. You know, in the previous one, we developed eyes on osteoid matrix. So this is chondroid matrix. Okay, last case of the chapter. Over to you.
So I'm presented with a frontal radiograph, an actual CT and MR in T1 and STIR weighted imaging. On the X-ray, there is a right chondroid calcified lesion arising from the right ileum. The lesion appears to be irregular. On the CT, the lesion appears to be pedunculated with more lucent areas anteriorly. On the T1 and STIR images, I can see a cartilage cap which is enlarged and concerning for a malignant transformation.
Excellent. I stop here. Well done. Well done. Now, this kind of a case, because of time factor, I have put that together. But just a recap, the examiner is going to show this to you, and you will pick up an osteochondroma, and the leading thing might be that there is a bit of pain. CT has got nil role. Don't ask for a CT, right? Ask for a MR. And on MR, this cartilage cap is thickened, means malignant transformation, means bone tumor center referral. So these kinds of cases have come in the exam again and again. Okay, again, a 5-minute break, and after the break, this will be candidate 4. Thank you very much, candidate 3. And the feedback form is in front of your eyes, and we will. Right now, this is the final part of the day. In the previous part, previous chapter was a longest chapter. This one is more interesting, multiple things. And in the previous chapter, we covered, the principles of how to diagnose bone tumors. Then we went into bone-forming tumors and tumor arising from the cartilage. These were the main things in the last chapter. Now, candidate 4, can you raise your hand, please?
Yeah, I'm here.
Okay, so your first case, please.
Okay, so I've got a frontal and lateral radiographs of the tibia and fibula in a skeletally immature male.
Can I guide you? Can I guide you because of time factor? This is a poor quality film, so these are better for you. Just describe this. This is a close-up of the same thing. And okay, this is a close-up of something which is here. Over to you.
Okay. So in the distal tibia, in the distal metaphysis, I'd say there is a lucent lesion which has a well-defined margin and slightly expansile. There is no periosteal reaction, no soft tissue swelling. So it has a narrow zone of transition and is only
eccentric or central. Please look at both of these.
Eccentric. And so my differentials in a male of this age would be a non-ossifying fibroma.
Excellent. And what is happening here? What is happening here?
So in the proximal tibia and the proximal metaphysis, I can see another lucent lesion with a sclerotic margin And again, no surrounding periosteal reaction, no cortical breach. So it has a narrow zone of transition, again, a benign lesion. And my differential for this would include a fibrous cortical defect. It's quite eccentric.
What is the size, cutoff between the two lesions?
3 centimeters, so less 2 or 3, so less than 2 and less than 2 is a fibrous cortical defect, and more than that is a non-ossifying fibroma, and they both have a fibrous matrix.
Okay, so if you see here, I am a strict believer in the term, what we call, I call it the book memory. So if you open your book and read this, this is from your book, from the Chapman, and you can see that this is from the table in the Chapman. Fibrous cortical defect and non-ossifying fibroma is the same thing, age group 5 to 25, less than 3, more than 3. Please remember, osteoblastoma was less than 2, more than 2. Osteoid osteoma versus osteoblastoma. And non-ossifying versus fibrous cortical defect, less than 3, more than 3. Now, the natural history, now these lesions are basically, they arise from the cortex, but of course they project into the medullary cavity. On one view, they might look like, they are central, because if it is central, your differential, the top differential will be a simple bone cyst. When it becomes eccentric, metadiaphyseal, and with involvement of cortex, then non-ossifying is up there. And it will have a bit of sclerosis, and there can be internal septations, etc. Both of these are what we call don't touch me lesions, means there is no role of biopsy. They can be diagnosed on radiology. The concept is that both of these lesions, there is a natural history, and they simply fill up. As the patient grows, till the age of about 30 odd, they just fill up and they become normal bone. Please also remember that non-ossifying fibromas can present with fractures. And so histologically speaking, we are not concerned. It's not a malignant tumor, but surgery-wise, they might do, they do some cement implants, etc. for these patients at times. So this is a non-ossifying fibroma. And this is another case. Look at this. It has, classical cortex sclerosis, narrow zone of transition, no cortical breach. If you see the AP view, you are a bit confused. What is happening? Is it just central? Then here you are more confident that it is eccentric and the cortex is also involved. Over to you, candidate for your next case.
So I've got a frontal radiograph of the proximal tibia and fibula in a skeletally immature female, and I can see that there is a lucent intramedullary lesion within the proximal diaphysis of the fibula, which has there's no surrounding periosteal reaction, no cortical breach, no associated soft tissue swelling. So it has a narrow zone of transition. And again, in the tibia proximal diaphysis, I can see another lucent lesion with a sclerotic margin. And again, a narrow zone of transition. So the lesion in the fibula, given the intramedullary location and a narrow zone, I'm thinking is a simple bone cyst. And the lesion in the proximal diaphysis of the tibia appears to have some calcification within it. Yeah, I think that's probably just
projectional. It is a bit of sclerosis. So what is this lesion?
Almost looks like a fibrous cortical defect to me.
You are absolutely right. Now, we stop here. Well done. But why have you said that this is a simple bone cyst? What was your thinking process?
Because it's lucent and the way it's occupying, it's quite central. It's not eccentric, and simple bone cysts tend to be central.
So your thinking was absolutely spot on. But the but is that in the narrow bones, basically fibula and ulna, these rules of eccentric or central, which I showed you on that diagram, they do not hold true because there is not enough place for the lesion, and those principles, they do not hold true. So your thinking was spot on, but this is a non-ossifying fibroma. So what the learning point is that in the exam, when there is a narrow bone, as in fibula or ulna, and you central versus eccentric debate, the small print is that you say whatever you have said, and then say that it might also be this. So that is how you. So this is a non-ossifying fibroma, and the learning point was that in the narrow bones, it might project centrally like this. Well done. So this is from a textbook which tells you the natural history, year 1, and after 3 years, 11 years, 14 years, it is filling up. So this is the natural history of fibrous cortical defect. Yes, please.
So I've got a frontal and lateral radiographs of the ankle in a skeletally mature male, and I can see a well-defined lucent lesion in the distal metaphysis of the tibia, which has a well-defined margin. There's no surrounding periosteal reaction. It does not cross into the epiphysis. It's primarily metaphyseal and eccentric in location. No periosteal reaction, no soft tissue swelling, and the underlying matrix does not have any calcification or within it. So it has a narrow zone, so it's a narrow zone of transverse, a benign lesion in this location, which is not entirely epiphyseal. I would include a
hint. Reconsider. Has it gone into the epiphysis?
It is epiphyseal, sorry.
Right?
Yeah. So epiphyseal location, so it is a subarticular location. So I would consider giant cell tumor as well because the epiphyses are closed.
Excellent. We stop here. The learning point here is that it was difficult on this case. Your eyes are picking up this as the articular surface. Actually, this view tells you that the articular surface here it is slightly proximal, so it is projected like this. So once you pick up that it has gone to the epiphysis, your differential becomes different, and which was the correct answer. Okay, well done. So this is a giant cell tumor. In giant cell tumor, look at the age group, and this is a very important point for the exam, 20 to 50. And the aneurysmal bone cyst is maybe at an age of 20 to 25 it stops. So this goes into a different age group. And chondroblastoma also, you remember that was a younger age group. So this one, I have already told you the importance of this lucent epiphyseal bone lesion. Sometimes I do a lecture on top differential diagnosis in MSK, top 10, and this is in the top 10. It's a very important differential diagnosis, and I've told you that include LCH if you can add LCH in these ones. This is the same concept which candidate 4 I showed you. Narrow bone, non-ossifying fibroma. And here I am showing you a GCT in a narrow bone. And you will agree that it is not eccentric. Classical GCT is eccentric, right?
Yeah.
Like this thing. Eccentric means on one side. But here, because there is not enough area within the bone, it can be more central, just to make the same point. One thing on MR, I don't think so anybody is going to show you an MR of GCT. As far as I know, it has never come in the exam. But one take-home point, maybe for your day-to-day radiology about MR of GCT, is that GCT has got some hemosiderin, and hemosiderin can be low signal, or not can be, it is low signal on T2. So the take-home point is that low T2 on GCTs can be seen. I don't think so. It's an exam thing. This is a GCT in short bones, carpal bones, tarsal bones. Please remember that because we are always taught these tumors on long bones, we tend to forget the short bones of the hands and feet. And all of these lesions, whatever can happen in long bone can also happen in these bones. So if you have got something like this, you remember in the previous chapter we did enchondromas. So with enchondromas, you can have giant cell tumor, as this example tells you. You can have simple bone cyst, you can have osteoid osteomas, you can have aneurysmal bone cyst, you can have brown tumors, you can have fibrous dysplasia. All of these things can occur. So keep your minds open, and the differential diagnosis will be on those other parameters like age and other associated things which you know. Candidate 4, your case.
So I've got a frontal and oblique radiographs of the hand in a 71-year-old female, in which I can see that there is arthropathy affecting the metacarpophalangeal joints predominantly, but in addition to that, and also the carpal bones, but there is a well-defined loosened lesions in the distal epiphysis of the radius, which has a sclerotic margin and has no surrounding periosteal reaction, no soft tissue mass. So it has a narrow zone of transition. So my differentials for this epiphyseal location and a benign lesion would include, again, I'd include GCT, but looking at the history of chronic wrist pain, I'm also thinking whether this could be an underlying geode, which can happen in degenerative.
Other than the parameters, very good. Other than the parameters which you have described, radiologically speaking, anything which in this case is slightly atypical for a giant cell tumor.
The age is the biggest.
Age is one. Anything else, radiologically speaking?
It is eccentric, but it
is eccentric.
It is abutting the articular surface as well.
Anything else? Can I? Okay, fine. Giant cell tumor. Look at notes, non-sclerotic margin, right? Classical giant cell tumor will have a margin which is non-sclerotic. And in your case, there is a bit of sclerosis, right?
Yep.
So that is another parameter. You see, all of these, if you are an examiner, you remember that each case in the Viva carries between 4 and 8 marks. You have to get 6 marks to pass. Now, as an examiner, how will I give 6.5 versus 7 versus 7.5? So all of these things, if you pick it up, I might give you half a mark more, though your diagnosis remain correct. So these are very important, the fine touch. And the strategy in Viva is that you plan for more marks so that you can compensate anything which you should aim for better marks so that you can compensate for any case in which you did not do well and your marks are less than 6, 5.5 or 5, and you can compensate with a 7 in another film. This is your last film, please.
So I've got a frontal radiograph of the wrist of a skeletally immature patient in which I can see a lucent lesion in the distal metadiphyseal region of the radius, which has a sclerotic margin and has some internal calcification There's no cortical breach and no surrounding soft tissue mass. It has a narrow zone of transition and it is a single lesion. So my differentials would include so because of so it's a benign lesion, my differentials would include a simple bone cyst, but it's not entirely intramedullary. Thinking whether it could be an intraosseous lipoma because of the fact that I can see a calcification which looks like a fallen fragment to me, but it's not the most common location here.
So go back to your diagram, you know that diagram which I showed you?
Yeah.
What comes to your mind? Eccentric, metaphyseal?
Eccentric also include non-ossifying fibromas and...
Non-ossifying fibroma classically will not go till the epiphysis. They will be more metadiaphyseal or diaphyseal even. This is a aneurysmal bone cyst, but it is not aneurysmally dilated till now.
Okay.
And that is why your mind did not go into it. But location wise, you know, that diagram, which I told you my favorite diagram,
Yeah.
you know, it is given there, right? And
Yeah.
this is what it is. This is and it is extra. Your thinking was absolutely spot on because you were thinking it's not central and things like that. But the only thing because of which you were confused is that it was not very expansile. So intentionally, I showed you this case, but you are right that it should be usually it's expansile, it should be bubbly, may occur secondary to some other lesion. Now, if you see all of these examples, and now here something is here, this is it. This one looks more central, but then on the other view, it looks slightly eccentric. And as I was telling you, that always the same lesions can be in the short bones. So remember that aneurysmal bone cyst in MR, and MR will show you fluid levels. So actually, I'll give you another case for a specific purpose. This is another aneurysmal bone cyst, and this one has got a fracture. Why is it aneurysmal bone cyst? Because it is eccentric. It is not central. Otherwise, a simple bone cyst will be top differential. And then there is a fallen fragment sign. Please remember that fallen fragment sign is not pathognomic for simple bone cyst. Some people think like that. No, it is not. It can happen in other conditions, and aneurysmal bone cyst is one of the examples. This is another case where we pick up multiple fluid levels and means we clinch the diagnosis. And in your book is a differential diagnosis. Fluid levels in bone, in CT and MR, these are the lesions, benign, malignant. Aneurysmal bone cyst, chondroblastoma, giant cell tumor. Oh, sorry, there is a typo here. Now, what you should be worried about is this thing, telangiectatic osteosarcoma. I'll come back to this point, and this is your last film, and then number 5 should be ready after you. Over to you. This is a very good case. Over to you.
So I've got a frontal and lateral radiographs of the ankle in a skeletally immature patient in which I can see there is an expansile lucent lesion in the distal metaphysis, metadiaphyseal region, and there is a soft tissue swelling, and there is also a periosteal reaction. Almost looks like the periosteum has been lifted up. The internal matrix of the lesion is not osteoid or chondroid, but the features associated are quite that of an aggressive lesion, so it has a wide zone of transition, I'd say. My differentials in a child of this age would include an Ewing's, that also include lymphoma, even though the bone matrix does not look as permeative here, but I'd consider an aggressive bone lesion here.
Okay, I am happy with your thinking of an aggressive lesion, so I'm very happy with that. But why Ewing's and why lymphoma? You know, it is a cystic lesion, isn't it?
Yeah, just thinking about because it's quite aggressive, and I was thinking what aggressive lesions would I expect for someone that age. It isn't osteoid, which makes me think it's less likely to be an osteosarcoma.
So can I just take your attention back to, let's say, any of these cases, right? For example, your case looks like this or looks like this, but then there are aggressive features which you have picked up beautifully. Yeah. So what is this? These are the red flags. Okay, I'll take over, and well done. You can please mute yourself. Aneurysmal bone cyst versus telangiectatic osteosarcoma, you have to worry about this thing. So you go back to this differential. There are benign lesions which have got fluid levels, and a telangiectatic osteosarcoma can also have fluid levels. Telangiectatic osteosarcoma has basically got, it will be a cystic lesion with, you can confuse it with aneurysmal bone cyst. I've seen in my career 2 medical legal cases like this where we mixed it up, and in just 2 weeks down the road, it just blew up. So the key thing is that literature will tell you that plain film is very important. Look at the margin of the lesion and go back to your basics. Whenever you see an aneurysmal bone cyst, look at the margin of the lesion. At some points, the margin of the lesion will have a narrow zone of transition. But if there is a wide zone of transition in a portion of the lesion, or things like periosteal reaction, as in your case, think telangiectatic osteosarcoma, and advise an MR. I don't have the MR of this case, but this was confirmed, telangiectatic osteosarcoma. This is from literature. It tells you in telangiectatic osteosarcoma, you can again get a lot of fluid levels, but there is some soft tissue. In Royal National Orthopedic Hospital, what they do is that they have got some criteria to diagnose an aneurysmal bone cyst on MR. More than 75% of the lesion must have fluid levels. And if they are worried about any solid component, they target it with a biopsy to rule out telangiectatic osteosarcoma. But in a 2B world, the case which will come to your exam, in your exam, will be a plain film. And here you have to raise that issue, that I'm worried that it looks like a bubbly lesion, but it has got some aggressive features. Here is an aneurysmal bone cyst, complete 100% fluid levels. We are not worried. Okay, candidate 5. Can you raise your hand, please? Over to you. This film is poor quality. I will show you a bigger version. Just concentrate on this one, and then I'll show you a lateral, which will be better.
So it's a APN lateral plain X-ray of ankle of a 13-year-old patient, which is demonstrating a lucent lesion in the dome of talus on the medial aspect with narrow zone of transition. There's no surrounding associated
Concentrate on this one. Well done. Please carry on.
There's no surrounding periosteal reaction. There is some pixelated, I mean, it's a zoom view, but it appears that soft tissue is slightly hazy, just adjacent to this lesion. There's no fracture through it. And there's a single lucent lesion with the benign features in the dome of the talus on the medial aspect in a 13-year-old patient. My differential in this patient would be simple bone cyst. It could be a Langer eosinophilic granuloma because there's no, it's a single lucent lesion. And the differential could be a brown tumor, but there's no associated features of the brown tumor there. So,
Okay, what is this where I'm pointing out?
there is some further kind of scalloping and scalloping of the cortex there, and then there's some adjacent soft tissue swelling or
So
calcification.
can it be a bubbly lesion which has gone out?
Yeah, it can be a bubbly lesion which has gone out. It's just like, for instance, aneurysmal bone cyst.
So what comes to your mind then? If this is an aneurysmal bone cyst, then what will this be?
If it's an aneurysmal bone cyst, this could be.
Let me ask you a theoretical question. What is your concept of secondary ABC? So these are ABC which actually arise within another tumor.
Yeah. So secondary ABCs are, as you mentioned, they arise in the previous tumors. For example, osteosarcoma or even GCT, they can arise within them. In a patient with this age, this is a most likely epiphyseal kind of lesion, single lucent lesion. So ABCs arising from that pre-existing lytic lesion in the dome of the talus. So I'm just trying to struggle to find out what this primary lesion could be in the dome of the talus, and then from there ABCs arising.
Okay, that's fine. I'll take over.
It's because of benign appearance because of narrow zone of transition.
Okay, thank you. Now, basically, if you remember this differential, you can get your answer. If you know this list, you can actually answer this question. And this is why I say that Chapman, or this is actually not given in Chapman, but differential should be, this concept should be with you. Secondary ABCs, these are the tumors: GCT, chondroblastoma, osteoblastoma, fibrous dysplasia, and non-ossifying, and as well as trauma. This is controversial. Some people think that trauma can cause it, post-trauma, but other things they do not. There is another differential diagnosis here, where do you see this? This is what I was talking about, location-specific lesions. One of them was osteoblastoma, and it is written in your Chapman. And sometimes two words in Chapman, can pass or fail your exam. And this is very important, osteoblastoma talus. So once you know it, come back to this lesion. This is a lucent lesion, which is subarticular, 13-year-old. It can be either a chondroblastoma or a osteoblastoma. In this particular case, it was a osteoblastoma. But in the exam, if you say either a chondro or osteo, I'll take both of them. And with that, it is an aneurysmal bone cyst. Aneurysmal bone cyst in the spine. In the earlier section, we did a lot of lesions in the posterior, osteoblastoma, and we did consider that the differential diagnosis will be an aneurysmal bone cyst. And look at this lesion, which is so much fluid levels, 7-year-old with aneurysmal bone cyst. This is a beautiful case. I will show you a bigger picture once you describe it. All of you should concentrate on this. This has come in the exam, and it's a very, very good case.
So it's a 14-year-old patient with a tibia and fibula, AP and lateral. which is having pain and swelling. So on the frontal view, I can see that fibular diaphysis has got an irregular cortices on the lateral
Excellent.
side.
Because you have picked up, I have given you a blow-up. Over to you.
So there is a kind of permeative appearance to that segment of the fibula with cortical irregularity. And there's also some soft, if I compare with the soft tissue density of the surrounding leg or distal leg, there may be a bit of soft tissue component, but it's very hard to say on this projection. But this is a aggressive lesion in the diaphysis of the fibula with cortical irregularity.
Anything else in the soft tissues?
Soft tissue looks a bit dense to me. There's no ossification. There's no mineralization of the. There could be just proximally. There's a focus of soft tissue calcification or ossification there. Just a single, I would say, focus.
What will you do next?
So this looks like Ewing's to me, but yeah, I would do an MRI of the patient. And
here you are. Let me guide you. These are stir sequences. This is T1 non-fat saturated pre-contrast. This is with contrast. And similarly, this is T1 non-fat saturated without. And this is a stir, and this is with contrast. So over to you.
So MRI with T1 non-fat sat stir, and the post-contrast is demonstrating a high signal intensity in T1 stir, and then there are areas of enhancement in the soft tissue post-contrast surrounding the lesion in the diaphysis, mid-diaphysis of the fibula, which has lost its cortex. There is also a bit of periosteal reaction around the fibula. These are highly concerning feature for aggressive tumor, for example, even in this patient. I would refer the patient urgently to regional sarcoma MDT.
Okay, I'll take over. Now going back, if you see, you picked up very well that there is a permeative bony destruction in the mid. The key finding, you picked it up, but you cannot correlate this. These are phleboliths. These are classical phleboliths. And then on this MR, this is a classical appearance of intramuscular hemangioma, which has got high stir, which has got some high signal on this pre-contrast T1, enhancement on post-contrast. If you concentrate on here, you see this this bit. This is that fibula where it is going in. So it will cross into the bone. It is causing permeative type of destruction, but actually it's a benign lesion. And if you look carefully, there might be some fluke levels. For this case, the key finding was to pick up this. And Ewing's will never behave like this. You see, it is sitting far away. This is the fibula where the lesion is sitting. And it's very classical for a intramuscular hemangioma. And intramuscular hemangiomas, classically, another viva question is, how can you confirm it? And what they do is in RNOH that they do a Doppler. And, this is very compressible lesion, and that is also considered diagnostic. So intramuscular hemangiomas, this is, just to make the same point that phleboliths, you have to look for phleboliths. Okay, over to you. Give me the diagnosis here, just the diagnosis, please.
It's a vertebral hemangioma. It's a cauterized type appearance.
Excellent. So this is the what we call the corduroy sign. This is the trouser of hemangioma of the vertebral body. Vertebral hemangiomas are very commonly seen in spine MR, classically, they will be high signal on T1 as well as T2 weighted sequence. If it is high signal on T1, don't worry then. I'm not going into the world of atypical hemangiomas, which has got many gray areas, and I don't think so that's for FRCR2B. That's beyond. So anything high signal on T1 as well as T2, it's a good news. Yes, please.
It's a skull X-ray of a skeletally mature patient, which is demonstrating a lucent lesion with calcification or trabeculation within it in a very geographical pattern. There's also some focal phlebolyths or densities within them, and I'm just wondering whether it's another example of hemangioma in the skull.
Right. So the description is that the hemangioma of the skull will have two types of appearance. It's a pathognomic finding, where it can have what we call a honeycomb or this kind of a sunray type of appearance. So these are multiple examples. This is case one. This is an example from Radiopedia on a CT, beautiful case. And this is another example. And then on MR, there will be enhancement. The hemangiomas, they sit within the diploic space. And the point of discussion here is that in your C and S in the Chapman, there is a differential diagnosis for skull vault lucency with sclerotic edge, and second one is skull vault lucency. One is with and another one is without. So hemangioma is given without, and it is not given with sclerotic edge. And I think you have to add that it can happen in both of them. Even our case here, you can see a bit of sclerosis here. You can see a bit of sclerosis. There will be other cases in which you will not find sclerosis. So another case for you.
It's a 45-year-old patient with a skull extrafrontal view, which is demonstrating a lucent, relatively ill-defined lucent lesion with a bit of permeative appearance on the left frontoparietal aspect. This has got a bit of focal density within it. Also, again, there is a trabecular pattern within it. My differential here in this age group, hemangioma is number one differential. Other differential could be a metastatic lesion from a known unknown primary, although unlikely. Patient is relatively young. These are my top two differential.
Okay, if you see here, there is a lesion here, and the same lesion is projected on this lateral, and there is a bit of marginal sclerosis. Now, what will be your diagnosis or differential?
So it's quite well-defined lesion with the marginal sclerosis. That means the
pattern.
Sorry?
What is the pattern of, the internal lucencies and look at
honeycomb kind of pattern.
So what is your differential there?
Hemangioma is my top differential here.
And what else?
It's a slow ongoing process, sclerotic. So I can't think of any other explanation of this.
Excellent. So this is what I was, at times the examiners will grill you, and you have to hold your confidence. When a lesion is pathognomic, means classical, and there is no differential, don't change your opinion. And this is what you did not change your opinion. So that's perfect. That this is a hemangioma, and this hemangioma has got that honeycomb appearance. And the point is that a metastasis or anything will not look like this. So this was my point. Skull wall lucency with sclerotic edge. In this differential, add hemangioma. And skull wall lucency without sclerotic edge, hemangioma is already given in your book. So if you can add this. I will cover this again in CNS. The skull I'll cover in CNS.
So,
yes, please.
It's a thumb DP radiograph, or yeah, it's a digit of thumb, which is demonstrating an eccentric lucent lesion with sclerotic margin in the tuft, with a bit of fragment within it.
There is nothing inside, so don't worry about it.
Okay, there's a breach of cortex here as well, so there's a fracture through it as well.
Breach of cortex, okay, this was artifactual. There is no breach.
Okay, so it's an eccentric lucent lesion with a sclerotic margin in the tuft of the phalanx, in the tuft of the finger or digit. Its appearance of benign, and again, differential here could be aneurysmal bone cyst, could be there, a hemangioma, glomus tumor can sometimes give this appearance. I would be guided by the history of the patient as well, but these are my top three differentials, and this is a benign lucent lesion.
Okay, I'll take over. Hemangiomas, hemangiomas will not give you this kind of radiology in the distal phalanx. Your top differential has to be, this is your differential, lytic lesion in the phalanx, poorly defined, well defined. And we are in this world here, it's well defined. And well defined is enchondroma. Of course, this will be secondary to some joint abnormality. Implantation epidermoid should be up there. And then glomus tumor and sarcoidosis, and other rare lesion not specific to the phalanges. These are very important. You see, this is the same concept which I was talking about in, fibrous dysplasia, ABC, giant cell tumor, simple bone cyst, Brown tumor, LCH, fibrous cortical defect. All of these things can occur. This is a case which I have already shown you in the first chapter, where this is a lytic phase of fibrous dysplasia and there is ground glass. This is very important exam case. So all of these things can happen. But this particular case is an implantation dermoid. Implantation dermoid, what happens is that this is post-trauma. So maybe a thorn injury or something. So part of the skin, it goes in and it starts growing. And when it starts growing because it is stratified squamous epithelium, and it is meant to grow with time. So this is the same concept as epidermoid in the skull wall or a cholesteatoma in the temporal bone. Please remember that a cholesteatoma in the temporal bone is the same thing as an epidermoid. When it happens in the temporal bone, we call it a cholesteatoma. Pathologically speaking, it's the same. And key point is that these lesions show restricted diffusion. So if I don't have a diffusion weighted scan for this, but if I had, this lesion will show restricted diffusion. Just to make a point, I'm showing you an epidermoid of the skull, which per se is a exam case. Usually epidermoid of the skull will have a sclerotic, it will be a lytic with a lesion with sclerotic margin, and it is showing restricted diffusion. So, okay, this is your last case.
Okay. It's a 47-year-old female, DPV of a digit of the hand, which is demonstrating an eccentric lucent lesion in the distal phalanx without any soft tissue component or periosteal reaction. It has got narrow zone of transition. There's a bit of sclerosis around the lesion, which is kind of end scalloping or slow growing process to demonstrate. It appearance are benign, and considering the age and location of the lesion, my differential here would be glomus tumor epidermoid cyst or lesion. Other differential could be, I mean, it's highly unlikely to be enchondroma. There's no expansile lesion here.
So out of glomus tumor versus an implantation epidermoid, what it is?
Glomus tumor is my.
Why?
It's showing a bit of scalloping, and there's the sclerosis around the lesion.
Okay, well done. Okay, we stop here. You can mute yourself. Now, glomus tumor is also known as a glomangioma. It's a very vascular lesion and it occurs under the nail. This is what it is. Look at this picture. It causes scalloping. It is very painful. It will be blue, clinically speaking, and very painful. And it will cause scalloping. This scalloping is on the dorsal surface of the phalanx, like this. And this is the case which we were seeing. On an MR, it will be high signal on T2. It can enhance, etc. But the key thing is that it's not sitting inside the bone. It is sitting outside and is causing scalloping of the dorsal surface. On the other hand, the implantation dermoid will be on the palmar surface, and it will be totally a lesion which has got marginal sclerosis because it is within the bone. That one was causing scalloping. This is the difference. Candidate 6. We have to finish in about 15 minutes, so a few cases to go. Now, candidate 6, can you raise your hand if you are with us? Candidate 6, can you raise your hand if you are not okay? So candidate 2 or 3, if you can raise your hand. So I've got quite a few hands, and let's see if I can see 6 there. 6, unfortunately, is not there. So I will give few cases to 2 and then a few cases to 3. So 3, you also be ready. Number 2, please.
Yes. So this is an AP radiograph of the left humerus of a 6-year-old male patient. There is a lytic lesion within the proximal aspect of the humeral metadiaphysis, which hardly expands. It occupies most of the bone, appears to be essentially location of some internal septations. My primary diagnosis is a benign lesion, most likely an aneurysmal bone cyst.
And why do you say an aneurysmal bone cyst?
Due to the expansion and the septi.
What is the location of the lesion?
Go back somewhat
to the diagram. Go back to the diagram. Is it central? Is it eccentric?
It's quite central.
Okay, so can you reconsider then?
It could be a simple bone cyst.
Here you are. So simple bone cyst number 1, because of the reason which I have told you, and it is more central. Please remember that there is a concept of what we call migration of cyst. So what happens is that in simple bone cyst, the cyst will be at a metaphysis, and it as the kid grows, the bone might the lesion might shift into the diaphysis. So this is a simple bone cyst. In differential, you can consider aneurysmal and then tell the examiner you're thinking, because it is central, it is in keeping with a simple bone cyst. And so 5 to 20 is the age. This is a simple bone cyst with a fallen fragment sign, nothing, another simple bone cyst with a fallen fragment sign. Okay, this is, you remember that I told you that in your book, lesion specified calcaneum, in talus osteoblastoma, in calcaneum lipoma was given, and a simple bone cyst was given. So this is a simple bone cyst in the calcaneum. Here you are. Intraosseous lipoma, calcaneum, simple bone cyst, calcaneum, osteoblastoma, talus. All of these are exam cases. And again, my emphasis: do not forget the same pathologies in the short bones. And this one is quite, bubbly, but it ultimately it proved to be a simple bone cyst. Okay, anything in the soft tissues?
Yeah, there's fairly poorly defined area of what looks like increased translucency in soft tissues around the mid-diaphysis of the left femur.
So you have picked up this thing, and
Yeah.
so what is the conclusion?
So because it seems to be increasing the transmission of the X-rays, it must be less dense than normal soft tissue, so potentially either a large cyst or a lipoma. Oh no, sorry, just a lipoma.
Lipoma, it's low density, means it has to be less than soft tissue. So on an MR, this was confirmed. If you see here, and it saturates here. Can you tackle this as a film?
The lateral radiograph of a right calcaneus vascularly mature patient. There's a well-defined lytic lesion in the anterior part of the bone.
Okay, I stop you because of time factor. What will you do next?
So it looks benign. My primary differentials between a calcaneal lipoma or a simple bone cyst. If there are some small calcifications within which favors lipoma, but if I wish to prove it, a CT could demonstrate the density of the lesion.
Oh, as a matter of principle, keep yourself to MR, right?
Okay.
You see, in the 2B world, just osteoid osteoma is CT, otherwise MR. And in the real world also, this is what we do. And this is an MR. What is your diagnosis? Just give me the diagnosis. Compare this with this.
It's a lipoma.
Lipoma. In the lipoma, there might be a central calcification, which occurs low signal here. Now, please remember that calcaneal lesions per se has got a differential diagnosis according to the age it changes. So we have already covered, lipoma, simple bone cyst, giant cell tumor, and then hemophilic pseudotumor, brown tumor. All of these can come in the differential diagnosis. Hemophilic pseudotumor in the calcaneum has come in the exam. It's quite a favorite site. I'll show you next time. Yes, please.
So these are AP and lateral radiographs of the left humerus of a 62-year-old female patient. I'm told there's a long-standing swelling in the arm. In keeping with this, there's an abnormality of the soft tissues around the proximal to mid-diaphysis of the humerus, which contains some calcifications within, although is mostly of low density.
Okay, what will you do next?
An MRI.
Here you are.
Okay, so on the MR, we've got axial T1 and STIR. And coronal, we've got another STIR. So there's a well-circumscribed lesion, which is high in signal intensity on T1 and low on the inversion recovery sequences. So that suggests fat because it's inverted. It's the same signal as the subcutaneous fat, within which there are areas of low signal intensity, which probably represent the calcifications that we saw on the X-ray. I think this is also a lipoma. If there's pain, I would just be considerous of sarcomatous transformation.
Okay, we stop here. You stop here, rather. I'll take over. The point is that, you see, this is a fatty lesion. Within the fatty lesion, you can see some solid component. And this solid component actually on post-contrast also enhances. So this is a liposarcoma. Now go back to the basics and see there is ossification or in the soft tissue. And in your book, there is a differential soft tissue ossification. And in liposarcomas, it can happen. So liposarcoma per se has come in the exam, and the basic concept is, it's a huge subject in radiology, which is beyond 2B. So don't overload yourself. The point to remember is that lipoma, there can be what we call well-differentiated liposarcomas versus undifferentiated or myxoid liposarcomas. Key point is that if a lesion is fatty and completely suppresses the lesion like this, you see, this has completely suppressed. We are happy that this is a lipoma, and we stop here. Some people think a size criteria of more than 5, they give some weightage, but we can stop as far as the malignant features are concerned. On the other hand, look inside the lesion. If the lesion has got septi like this, look at this. Thick septi more than 2 millimeter, you should be worried. If there is globular or nodular non-adipose tissue, like this case, you should be worried. And if the fatty component is less, you should be worried. Size greater than 10 centimeter, you should be worried. So then it is a malignant transformation. And if you see a lesion like this, you can do a biopsy because it gives you a target. But if a lesion is well differentiated and it contains only a 2 millimeter, or 3 millimeter thickness of septi, you cannot do a biopsy. You just remove the lesion. To do a biopsy here, though radiologically speaking, it looks like malignant, but we can do a biopsy. We will do a biopsy. Why? Confirm the diagnosis, and it will help plan the surgery. It will require a larger, excision of the margins, etc. So these are a few concepts, but in a FRCR exam, liposarcoma has come in the exam, and you should think like this, that within the lipoma, if I find any soft tissue, if I find thick septi, I will raise that issue. Okay, last few films are left, and all of these are, except for one odd, are for classical 2B films and for observation. So this is over to you.
So this is a frontal chest radiograph of an adult patient. I don't see any acute focal lung lesion. So going through review areas. Saying abnormality is not striking. there looks to be some cortical thickening of the inferior cortex of one of the ribs on the right. I think that's the
Excellent. More ribs?
right rib.
Okay, conclusion.
There's an area of well-defined periosteal reaction in the right rib of an adult patient.
Here? Or here?
Yeah, there. Oh, okay, so it's multiple ribs then. So in an adult, my first concern would be metastases.
Actually, this is not a periosteal reaction. Maybe for you it is projecting like that. So let me guide you. There is no periosteal reaction. What is your conclusion with these ribs?
And they look actually quite widely spaced compared to the adjacent ribs either side.
Very good, very good.
So I think there might be a sort of chest wall mass that's splaying the ribs and causing some reactive sclerosis.
So I am going into a differential diagnosis from your chest world, which is classical for your exam. And this is what? Heading of the differential?
Rib splaying?
Inferior rib notching.
Oh, notching, okay, yeah.
Classical, absolutely classical 2B film, where you can see that there is rib notching here, there is rib notching here. You picked up this thing very well. This kind of a finding you will only pick up when we go through your protocol and ultimately you pick it up. It's a subtle finding. And in this particular case, there was neurofibromas. This is a case of neurofibromatosis, neurogenic tumor. And the differential diagnosis, rib notching inferior surface. There is a differential diagnosis in your book, inferior surface and superior surface. So neurogenic is what we are talking about. This is your last case, and then number 3 should be ready. This is also a classical 2B film, absolute classical.
Again, a frontal chest radiograph of an adult patient. There's some atelectasis in the left lower zone. Otherwise, the lungs appear clear. I'm not sure it's projected very well for me, but I'm trying to assess the bones.
What is this?
There's some increased soft tissue over the right apex with what looks like possibly some ill-defined calcification within the region of the...
So don't worry about calcification. There is a soft tissue. Please continue.
Okay, so there's a soft tissue mass located in the region of the right apex that seems to be inferiorly displacing the pleural edge and causing some abnormality of the mediastinal contour in that region.
Is it in the anterior mediastinum? Is it in the posterior mediastinum? Where is it?
So I think the cervicothoracic sign is positive.
And what does that mean?
Well, that's the bit I can't remember.
Okay, well done. Okay, classical exam case where what happens is if you pick up a mass here. Now there is a widening of the paratracheal stripe, but more superior to the level of the clavicle, you see this mass. Now this is cervicothoracic sign. What is cervicothoracic sign? Basically, if you go back to your anatomy, superior to the level of the clavicle, the lung is quite narrow. So if a mass is anteriorly placed, there is no air anterior to the mass, and that mass will not be well defined. It will be ill-defined. On the other hand, if a mass is posteriorly placed, there will be lung anterior to that, and it is a sort of extension of what we call the silhouette sign. So because of which the margin of the mass will be will be crisp and sharp. This is known as cervicothoracic sign, and this indirectly means that there is a posterior mediastinal mass. Classical exam film. So they will show you this. They will ask you cervicothoracic sign. They will ask the explanation. What will you do next? And the answer will be cross-sectional imaging. You remember the differential diagnosis, and one of them is neurogenic tumor, and this was a neurogenic, classical dumbbell-shaped tumor which was going out. So this is it. This is posterior mediastinal masses in adult, and also in children will have nerve sheath tumors in differential. Okay, candidate number 3, can you raise your hand? Okay, over to you.
So frontal and lateral radiographs of the tibia and fibula. There is a poorly defined central proximal metaphyseal lesion with surrounding sclerosis. The bone appears to have a slightly primitive pattern, and the zone of transition appears to be quite wide. On the lateral radiograph, there also appears to be some periosteal reaction. Overall,
conclusion.
Sorry?
Your conclusion.
So aggressively,
I'm cutting you because of the time factor.
Aggressive lesion, and I'm concerned with the fever about osteomyelitis, Brody's abscess, septic process. How to correlate with an MR?
Okay, I don't have an MR, but I just want to ask you differential. So you have talked about aggressive process, absolutely fine. Infection, absolutely fine. What else?
So since it's
ESR, pain, fever.
Okay, so it can be a malignancy such as osteosarcoma or Ewing's, Langerhans cell histocytosis.
I stop you here. So the take-home point is, I've shown you MRs in infections also. MR is the correct answer. You will ask for an MR because MR can at times differentiate between the two, infection versus a tumor. Please also remember that the main differential is infection versus Ewing's. Ewing's is the king tumor. FRCR Ewing's, always consider Ewing up there, and it's very common also, relatively speaking, I mean to say. Also remember, clinically speaking, Ewing's and osteomyelitis at times cannot be differentiated, and it might have fever. The patient might have fever, glazed DCR, ESR, and pain, etc. So this was Ewing's, but the way you have tackled it is absolutely fine, and the differential is absolutely fine, 0 to 5 to 20. Now the cases which I am showing you, all of you, please concentrate. These are, I think 3 or 4 cases are left. These are just cases, and these are observation cases. Observation cases are cases in which once you pick up the findings, it's dusted. And so these are only left, and all of them are extremely good film. This particular film is very good, but this was from our hard copy collection, so we scanned it, so that's why the quality is poor. Having said that, it's a classical 2B film. Over to you.
So over the right midzone, there's increased density, and when you compare the soft tissues on the right compared to the left, there's increased soft tissue thickening.
Look at the ribs, please.
The ribs are also sclerosed, and there's increased density in the posterior ribs on the right. So I'm concerned about...
Do you think this rib is normal, where I'm pointing out?
No, it's not normal. It appears to be expanded, it's sclerotic. It looks like it's infiltrated.
Do you look at this soft tissue versus this soft tissue, any difference?
Yes, on the right-hand side, the soft tissue is increased.
Your conclusion, what is your conclusion?
So I'm concerned about the chest wall lesion, a soft tissue sarcoma of the chest wall. Be my 2 top differentials.
What is the age of this patient?
So the epiphyses appear to be closed. They don't have much degenerative change. It's probably a middle age.
Look at this one. Look at this one.
All right. Okay. So they're open. So in a child, I'll be concerned about metastases, such as a neuroblastoma. Metastases can present like this. It can also be Ewing sarcoma of the chest.
Okay. So you see, this is a classical exam case. The key thing is look at the age of the lesion. You know, it is at the edge of the film. We call it edge of the film, right? And then you pick up, there is something wrong, and initially you think there is consolidation. Look carefully, there is soft tissue thickening. And then you look at this destruction of the bone. So it's a chest wall lesion presenting like this. Classical differential will be the same. The top two will be infection versus Ewing's. So they have to be on top. You can keep eosinophilic, LCH, etc. in the differential, but those will remain. Another film which has got subtle findings. Over to you.
So in the proximal femur, there appears to be a periosteal reaction on the lateral aspect, and on the distal.
Yeah, so this thing is a fibrous cortical defect. You have picked up a periosteal reaction. Do you think this is a normal marrow here?
No,
Close
it's no, the marrow appears to be heterogeneous and slightly sclerotic.
What will you do next?
MR.
Okay, so this is another example. You know, if there is no periosteal reaction, it will be next to impossible on this resolution to pick it up. But if you look carefully, you know, this marrow is not normal. You remember the words which I showed you, moth-eaten versus permeative, and this marrow is abnormal. Of course, the main finding becomes easy because of periosteal reaction. On MR, it is horrendous. It is an Ewing sarcoma. Look at the bone. There is no normal marrow. Low T1 and high on the stir sequence. Last few cases are all observation films, classical 2B films. So please concentrate, develop your eyes on these. These are classical exam films, and these are all observational films. Over to candidate 3.
So in the left shoulder, there's a large soft tissue component surrounding the proximal humerus with abnormal medullary density. There also appears to be some scalloping of the lateral humerus. So in a 14-year-old, then in this region, I'll be concerned about a osteosarcoma given the large soft tissue components.
And you will do an MR, right?
I'll do an MR.
Soft tissue components in a young child, most common tumor is Ewing's. Ewing's, you know, has got, classically speaking, big soft tissue component, right? So Ewing should be up there. In this age group, 14 years old, you have to keep it up. But I wanted to show you this plain film, and it's a good resolution film. Develop your eyes on this. Look at this. This is the cortex. This is the cortex. First of all, something is here, right? Then you look at the medullary cavity. Look at this medullary cavity. As we go in, look at this medullary cavity. There is something wrong. Even if you pick up that I am a bit worried and something is wrong, actually there is a bit of permeation, you know. Look at this pattern. It doesn't make sense. And with that, the soft tissue. So on MR, again, completely abnormal. And if you see, this is a T1 weighted sequence. And look at this soft tissue which is surrounding. Look at this soft tissue which is surrounding it. Look at this soft tissue. Classical for Ewing sarcoma. The differential will be lymphoma. Lymphoma can also cause a soft tissue like this, but usually not as thickened. Number 2, lymphomas in this age group with this kind of radiology are much rarer. Out of 100 cases, maybe 5 of them might be lymphomas. But radiologically speaking, yes, lymphoma can be kept in the differential with this fine print that the soft tissue might not be as much. So this is classical Ewing sarcoma, and this picture also tells you what happens. Another observation film, I think the second last of the day. Over to you.
So in the lateral iliac crest, there appears to be increased.
Which side?
Left side.
Okay.
The iliac crest. So in the iliac crest, compared to the contralateral side, there appears to be a periosteal reaction or cortical irregularity. there's also possibly some lucency within the iliac, in the medullary cavity within the ileum. The appearances overall are aggressive, and again, I'll be concerned about an aggressive process such as Ewing's osteosarcoma or infection, and would recommend an
Okay,
MRI.
very good. If you see this case, very subtle findings, and this is, you are expecting this kind of an observational film in the exam, where you see this cortex versus this, something is there, then you start challenging yourself, oh, something is happening there, compare it with this side, maybe there is something. And this was a Ewing's. If you read literature, Ewing's will tell literature will tell you that sometimes it's very difficult in Ewing's, or you can confuse an osseous matrix. You remember we were discussing osseous matrix in the previous chapter, and you can have a discussion in your mind, oh, is there osseous matrix? So literature tells you that at times in Ewing's, the periosteal reaction is so exuberant that you can confuse it, and it will give you a bit of sclerosis like this. Having said that, it's fine. In the exam, it's fine. You've done your duty once you pick it up and ask for an MR, not a CT. But even on this CT, you can see this soft tissue, how thick it is. Actually, this is not the last case. So in this case, there are metastases. Now, all of you concentrate on this. And there are 3 metastases.
Okay, so there's one in the posterior left rib.
This is one. This is second.
Hello?
Yes, we are listening, please. Please. So I want you to pick up the third metastasis.
Okay,
Bony
so
metastasis.
Bony metastasis. So there appears to be, so there's one in the left posterior rib, and there's one projected over the right scapula. And
No,
I think there's
this
one.
Excuse me. This one and this one, I have myself told you, right?
Right.
I want you to pick up, there is another one, and I want you to develop your eyes for the third one, classical exam one. Please, over to you. Where is the third metastasis?
Is it in the left scapula?
No. I'll give you 20 more seconds. Look at the spine. Let me give you a hint.
So in the lower scapula, I think it's around T12, there's an increased area of lucency.
Okay, I'll stop you because of the time factor. Please remember, these are the classical observational films. And in these types of film, right now I am rushing you, so don't worry because of the time factor. Otherwise, I would have given you the time to go through it. You go through your protocol, examiner has told you spine, so you start describing it in detail. Having said that, look at this. This is T1. You see the transverse process, this is T1. What is happening here? You see this destruction? And this is C7. And what is happening? There is a definite lesion sitting here. So this is the type of observational film for which you have to pick up, develop your eyes. And the key thing is to go through your protocol. You will never pick these things up initially. Start describing the X-ray. Never keep quiet. If you keep quiet, then your adrenaline will be released, and you will be so much under tension that all of your thought process goes down the drain. Keep describing. Number 2, if the examiner gives you a hint, go in details. And if the examiner says, review the thorax, start describing, I'm looking at this, I'm looking at that, I'm looking at that. That should be your technique. Think aloud, and that will give you the leeway. And even if you don't get it, the examiner will give you some marks, because you have gone through your scheme. This is a case of clavicle, periosteal reaction, and the differential will be Ewing's versus infection. This is a case of again an observational film in which this tumor was missed actually by us, and it became a sort of a complaint type of a case. If you see here, why I am not giving it to you, because the resolution is not very good. By the way, candidate 3, have you picked up any finding?
In the humoral head, I think it's the medullary cavity is slightly primitive.
Okay, I will take over. You see, this is humerus is fine, this is fine, this is fine. Do you see this lucency in the acromion? Right? So I don't blame you because the resolution is poor, but on PACS, it was very well visualized. And there is a lucency sitting there. And there was a huge tumor sitting there. Absolutely huge. And these were some metastases. You see, it's completely destroyed and we missed this. So this is a type of case which can come as an observational film. Last case of the day. And this is a beautiful film for the same reason. It's an observational film, classical 2B. 466 people are still with us. If all of you can concentrate on this.
So there appears to be increased density in the left paravertebral region behind the heart shadow.
This thing, I am not worried. Please continue.
So I'm looking at the remainder of the lungs. There's no consolidation or collapse. Incidental note of an azygos fissure. So I'm reviewing the bones. I can't see any abnormality in the clavicles or the proximal humor bilaterally. The glenohumeral joints appear to be preserved. Looking at the ribs, I can't see any destructive rib lesions. And looking at the spine posteriorly, there's a vertebra that appears to be slightly more lucent.
Don't worry. Look at the soft tissues, please.
So in the right, projected over the right clavicle, there's increased soft tissue swelling compared to the contralateral side. So it looks quite expanded. The actual bony clavicle doesn't appear to have any associated erosions. So this may be a soft tissue lesion of the right.
Anything happening to the scapula?
There's some lucency around the superior glenoids.
Angle, superior angle.
Yes, so the spine of the scapula, there appears to be an aggressive periosteal reaction on the right-hand side.
This is a beautiful film for 2B and for observation. And if you see here, look at this soft tissue. And you can see normal fat plane here. And then you compare it with this, there is a definite finding. And there is no soft. And then you see this scapula and this scapula versus this scapula. So there is something happening, a bit of permeation, expansion, or destruction, whatever. So once you pick it up, then you, I'm showing you a closer, there is a bit of a technical problem in here. But just to make the point that this is that soft tissue and here was that bony destruction. This is too easy, of course, but here it becomes a bit difficult. And on MR, you can see a lot of soft tissue. What is your conclusion with this MR? Soft tissue, so much soft tissue with the tumor.
So it could be a liposarcoma.
Why do you say liposarcoma?
There's a large soft tissue component. I suppose given
large
that
soft tissue components, Ewings, if the age, because Ewings can be up to 30 at times. And of course, lymphoma should be up there. Lymphoma, right? This was Ewings. And then, so this was, I believe, the last case of the day. And last few cases which I showed you were all observational films. If you pick it up, the key take-home point is, I'll just give you the final tip for the exam. In these cases, in observational films, you can mute yourself. Thank you very much, candidate 3. Last tip of the day is regarding observational films in the exam. And listen to this carefully. What will happen in the exam that there will be cases in which the findings will be subtle and you are never going to pick them up initially. I have given you a few examples in the last part of the day. And the key thing here is do not keep quiet, never keep quiet. After 5 seconds, 10 seconds, just start describing and say that I do not see any finding on the obvious findings. So I'm going to go through my protocol or whatever. And you start describing lungs are clear, heart is this, hilum is this, trachea is this. And as you go, three things will happen. Number one, if you keep quiet, you will get very tense, your adrenaline gets secreted, and then you will lose your concentration and you will be terrified. And number two, when if you are describing your protocol, you are, what I say, thinking aloud. So the examiner is gaining something out of it and seeing your thought process. And even if you fail, the examiner might give you, let's say, 5.5. But if you keep quiet, the examiner might give you 4. That is the difference. And the third thing is that when you are going through your protocol and you say, I am looking at the bones, and the examiner might give you a hint. Okay, you have described the clavicle, can you have a second look? And there might be something in the clavicle. And final thing is that if the examiner gives you a hint, review the bone, review the soft tissues, or review X, or review the hilum, that is your last chance. So take the chance and now go into details and start describing it in details, giving yourself time. That's the key. So for example, it's bony thorax. You start saying that, I'm looking at the ribs, I'm comparing the right first rib with the left first rib, it's normal. I'm looking at the right side with other rib, second rib is normal, third is normal. Go into these details and you will pick up the find. But don't panic. Keep talking and that will help you. Right? So now the plan is that because of the poll, we will have the last session of MSK will be on Monday. I will look at my schedule. I'm not very clear about my schedule. I would like to start as soon as possible classically at 5 o'clock, 5:30, or maybe max 6, depending on and hopefully we will cover it in 2.5 hours. And that will end the MSK bit. On Thursday, we are starting GIT. So we will continue with GIT. What I will do is that I will put up, once I've made up my mind, and it might be tomorrow, I will put up a meeting on the web portal. And if you log in, you will see the meeting on Monday. What is the start time? And we will call it MSK 5 or whatever. And on Thursday, we are starting GIT. And we'll continue with GIT. We might do a GIT session on the weekend also. I will see my own schedule. Next week, look out for an interventional radiology FRCR course also, which will be about 3 hours. So we will show you cases which have come in the exam, and we will show you the basic questions which can be asked in the exam. And somebody else from our faculty will take that course. But GIT, I'm going to teach you. Okay, then, thank you very much. And final bit is that the feedback I am going to put once again for you. And if you, before logging off, if you can just sign up the feedback.